about the tubercular meningitis, traditionally it doesn't include the other form of the CNS meningitis like the tuberculoma, cerebral abscess or the spinal tuberculosis. If you look at the age group which is most affected, that it is the 2 to 5 years of age, and in adults the mostly are immunocompromised, whether they are living with HIV or malnutrition or some other immunocompromised conditions. The important thing is that if we do not treat it, it is uniformly fatal, and even after the treatment, the sequelae remains in about 1/3 of the cases. So it is very important to tackle this disease as early as possible. Now see, we are the most populous country in the world, and we are diagnosing tuberculosis. We are having a load of tuberculosis in every form, whether it is pulmonary or the extrapulmonary tuberculosis. But this is not so easy to diagnose the tubercular meningitis in the early stage, because by few slides we will get to know that it is the early stage, catching the disease at early stage is most important. If we talk about the natural history, then the age we talked about, there is some protection also against this disease. Suppose the patient or the community is having a good number of BCG immunization, this community is protected. However, the malnutrition, HIV co-infection and the helminth infestations are the risk factor for development of tubercular meningitis. Also, the most of the damage caused by this tubercular meningitis is not due to bacteria, it is the immune response of the body. So we do not know that what immune response we are having against this particular tubercular bacteria. However, some bacteria are also, mycobacteria are also virulent, like the lineage X, what we call the Beijing strain. So the first challenge comes to our mind that why some people develop tuberculosis in the same family, or suppose the tubercular meningitis in the same family and the others do not. So this is not very clear at second. If you look at the epidemiology, we see that the the challenge number 3. Now continuing with the pathogenesis, the 3 prime focus are the inflammatory meningeal accumulates, there is vasculitis and perivascular inflammation, and the disturbance of cerebrospinal fluid circulation and the absorption. And we know that most of the things, most of the complications, most of the presentation occur by these 3 mechanisms. However, sometimes we find that there are paradoxical changes, like whenever we start the treatment in the initial few weeks, sometimes there is deterioration of the clinical symptoms. Sometimes there is acute tubercular formation or worsening of the hydrocephalus or the aortic asthmatic or the spinal adenoidotic meningitis. In that time also there is elevated neutrophil and protein in the CSF. So sometimes it becomes very difficult to diagnose whether the disease has progressed or is it just a what we call the paradoxical reaction. We consider that it is the Irish type reaction, that is कि जब हमारे शरीर में दवा जाती है तो इम्यून मजबूत होती है, उसके कारण से ऐसा होता है. But sometimes it is very difficult to diagnose whether it is drug toxicity, drug failure, or is it a paradoxical reaction. So this may be a challenge in the management. If you look about the clinical feature, you know that it is a slow progressing disease. It remains mild in the initial 2 to 3 weeks with vague symptoms like apathy, irritability, anorexia, behavioral changes. It is the onset of meningitis which opens our ears and eyes. That the fever has appeared, the headache and vomiting is there, meningeal signs is there, and with background we assess, we think that suppose it is it may be a tubercular meningitis. However, with focal deficit we become very sure that it is tubercular meningitis. So the challenge, most of the clinical features are non-existent. They have to differentiate it with the bacterial meningitis and the fungal meningitis and other subacute forms of the meningitis also. Then we go to diagnosis. We do the chest radiograph. It's about 20-25% of the adults who can get some focus or some board focus in the lung. However, in the children, about 50 to 60% of the children with CVM may have the biliary pattern or some active focus. Now, the most important thing in the radiological diagnosis becomes this CT, the scan, or the MRI of the brain. The thickening and enhancement of the basal meninges with formation of exudates, hydrocephalus, periventricular edema, infarction, and sometimes the mass. These are the gross variation in the CT or the MRI image. We know that MRI is better because it may predict the onset of complication also. How and granuloma can be differentiated whether it is cateated or non-cateated with the MRI. Also, the electromeningeal tubercle can be found, and the posterior fossa region can only be found with accuracy with MRI than the CT scan. However, we know that these are not easily available at each and every patient. The diagnostic, which is essential for the diagnosis, remains this CSF study. It may be turbid or it may be clear. The counts are usually 100 to 500 with lymphocytic predominance. Initially, it may be neutrophils. Protein are high, usually in the range of 100 to 200. Glucose level is less than 50% of the corresponding blood level. Opening pressure may be high if some blockage is there or hydrocephalus is there. We have to do the India interpretation, gram stain and the magnetic staining. That should be negative. Now the demonstration of AFP, if you are demonstrating in the CSF, then it is the gold standard. We know that the culture remains the gold standard. However, we do the staining. With the staining, the sensitivity is very poor, 10 to 15%, and the centrifuge samples may be high, but usually it is 10 to 15%. Now CSF culture, we know that it is a lengthy process. Nowadays the liquid culture has come, which gives the diagnosis in 2 weeks. However, 2 weeks is very important for these kind of patients with sensitivity of around 50 to 60%. So the culture has to be sent, AFB has to be done, but it is not necessary that it is guiding you
Hello.
So is it paracentamide is BAPICON followed by 2?
Sorry for the interruption, doctor. We have last 1 minute.
Yes, I'm fine. The difficulty remains in that the penetration of the drug is not clear. However, the other things like the high dose of rifampicin and paracentamide has been tried, and it is under the trial that it can give better result. The corticosteroid, it is beneficial in modern, it has to be given for initial 4 weeks. Aspirin, maybe given thalidomide, erythroitis is there, and surgical intervention may be needed. So the challenge again remains that the guideline is not there for the treatment of tuberculosis. Even following for 2 years is expected, however, it is not always possible. We treat on the lines of the guidelines of the pulmonary tuberculosis. Now coming to my last slide, that yes, challenges are there in the management of tuberculosis meningitis because most of the things has been adapted from the pulmonary tuberculosis. There is unclear differentiation between adult and childhood tuberculosis. Incomplete understanding of the best mechanism of both immune system is there. Thus, the management is not tailored for children and the adult. Uncertainty remains about the dosing, the optimal anti-tubercular medication, and sometimes the patient gets the less treatment as he should receive. Now, the government policy is not very clear because of all these challenges. The government is also confused. So we can say that the care cascade of the tubercular meningitis is still incomplete. A large gap exists at every stage from incidence to diagnosis, from diagnosis to treatment, and from
Hello.
treatment initiation to regular outcome. The specific challenges of rehabilitation following treatment and implementation is a big challenge. Surveillance data for TBM is limited. The cases are rarely reported, and all hospitals do not have the TB reporting unit, which is a huge gap in national and regional TB reports.
Thank you, Dr. Abhishek, for a nice deliberation on tuberculosis meningitis. And so we are already late, so we don't have any time for question. I will ask Dr. P. Ram Kedia sir for his final comments.
Thank you, Dr. Abhishek, for your nice presentation. But one request, you should be available with us so that we should talk to you at various aspects of these subjects. These are very common things. We don't diagnose, it's our misfortune, but this is a very common problem in our clinical practice. And once you have mentioned just the role of corticosteroid for 4 weeks, but I think so far many books suggest it should be more than 4 weeks, then it should be tapered. What's your suggestion?
I completely agree. It was the recommendation, it is at least for 4 weeks, but it all depends
Yes.
upon the clinical feature and clinical recovery. As soon as we are taking the benefit of corticosteroid, we can continue even more than 4 weeks.
Hello.
और इसको देना है, उसके बाद में tapering में क्या और भी लग जाता है, and then gives the best result. This is very important topic, sir. A personal discussion among one many question arises. It is just the experience that this discussion becomes very important. And because of sir fever and ill health, I could not travel. I apologize.
Okay, thank you.
Thank you so much, Dr. Abhishek. And with this, let's move forward to the next talk of the day. And I would like to request the next speaker, Dr. Neeraj Saraf, to please join us on the dais.
Good morning, everyone. I hope I'm audible. I'm Dr. Neeraj Saraf. I'm DM neurologist. At the outset, I would like to thank everyone for giving me this opportunity to speak about acute ischemic stroke. I have no actual or potential conflict of interest in relation to this program or presentation. Hippocrates first recognized stroke over 2,400 years ago. At this time, stroke was called apoplexy, which meant struck down by violence. In mid-1600s, Jacob Wepper described stroke as bleeding in the brain or blockage in one of the brain blood vessels. Subsequently, the stroke was categorized into bleeding into the brain or a blockage. This led to the term of stroke or cerebrovascular accident. As per one study, the incidence of stroke in India was estimated to be 263 per 1 lakh population, which is far greater in number when compared to Western population. In USA, the stroke has dropped down to 5th leading cause of death, while in India, it is still at abysmal 2nd. Barring death, the morbidity and quality-adjusted life we provide to the survivors is quite pathetic. In United States, they thrombolize around 7 to 12% of all the stroke cases, while we are at a dismal rate of 0.5%. So when did it all start? The first publication with the thrombolytic agent in stroke was published in JAMA in 1958 by Bernard Sussman. So you can see the first thrombolytic agent was used more than 70 years ago. I think the keyboard's not working. Just a second. सेंसर सेंसर पे लगा चलो कर दो सर. So I would continue. When we see a stroke patient who present to us with an acute left hemiplegia or a stroke syndrome, the first and the initial investigation we get done is a CT scan. Absolutely normal CT scan is the most common finding in an early ischemic stroke. But there are a few pointers which we have to keep in mind when we see a stroke patient. One of the common things what we come across is a hyperdense MCA sign, which has 100% sensitivity and around 30% specificity. It is less specific because calcification, blood flow, and hematocrit can affect the appearance. The unaffected site must be normal when compared to the affected side. The other thing when we see in a cross section of the Sylvian fissure is a MCA dot sign, which is nothing but hyperdense MCA appearing as a bright dot. The insular ribbon is often one of the first structures to be affected. It appears as a thin line of gray matter next to the dark gray subcortical area. When gray or white matter differentiation is lost, the insular ribbon itself is lost. As you can see in this slide, we have a healthy insula over the right side, appearing as 3, while over the left side, we can see a damaged insula. As ischemia further develops, both white and gray matter will begin to appear hypodense, that is darker, and continue to darken over time. When we see an initial stroke patient with a normal CT, what we evaluate is an aspect score, which is quite important to thrombolize the patient. According to the aspect score, the MCA stroke is divided into 10 areas depending on the regions of the brain involved. The maximum point it carries is 10, and depending on the regions involved in the brain, we subsequently deduct 1 point from the score of 10. For example, at the level of the basal ganglia, the caudate lentiform internal capsule, the insula, and at the same level, the cortex of M1, M2, M3 are each given 1 point. At the level of the lateral ventricle, just superior to this region, they are given as M4, M5, and M6. We deduct 1 point from each region. So, suppose a patient who comes to us with a stroke having hypodensity in this area, and the aspect score is equal to 7, it products worst functional outcome at 3 months, as well as risk of symptomatic hemorrhage. To say what I mean is, if you have a higher aspect score, it is safer to thrombolize. If the aspect score is lower, then the risk of hemorrhage after thrombolysis is quite high. So aspect score in general predicts what we are going to get the result after thrombolysis. So acute ischemic thrombolysis is the dictum nowadays. We need to thrombolyze more and more patients so that we can give them a good quality of life and they can get back to their working condition or pre-morbid condition. In December of 1995, NINDS in USA reported its success in significantly improving the outcome of ischemic stroke by using IV RTPA if administered within 3 hours. 20 years down the line, RTPA is still the most effective treatment in ischemic stroke patients. The eligibility criteria is that they have to be 18 years or older. There has to be a clinical diagnosis of ischemic stroke causing a measurable neurological deficit. The time of symptom onset should be less than 4.5 hours before the treatment has begun. And CT should be consistent with acute infarction, or there should be a normal CT scan. There's a huge list of contraindications starting from intracranial hemorrhage to an improving stroke to any active internal bleeding, any bleeding diathesis, which is quite difficult to memorize or remember. So the most not so complicated is you have to rule out an ICH doing a CT scan, evaluate any bleeding risk by history of bleeding from anywhere in the brain, any history of drug history like aspirin, heparin, or warfarin, recent acute coronary syndrome or CVA, and blood pressure has to be managed, CVG checked and controlled. This is a pre-thrombolysis checklist before we begin a thrombolysis. After confirmation, an NIHSS score has to be documented, determine the definite time of onset, neuroimaging to rule out ICH, and check inclusion and exclusion criteria. A consent of thrombolysis has to be obtained after explaining merits and demerits in detail. An 18-gauge cannula has to be inserted in both the arms. NIHSS is a clinical tool which is very handy to use. It is available in all the mobiles and all the medical tools, which can be easily scored with hardly takes half a minute to 1 minute. It is composed of around 11 items, and each of which scored a specific ability between 0 and 4. The maximum possible score is 42, with the minimum score being 0. An NIHSS score of 5 to 20 is ideal for thrombolytic therapy. However, higher NIHSS score carries more risk of bleeding. But we have to remember there is no contraindication on NIHSS score. This has been the most studied RTPA molecule, that is alteplase. Nowadays, we are also using tenecteplase at 0.25 mg per kg body weight. But the most of the trials and studies which have been done has been done with alteplase. The total dose is calculated by 0.9 mg per kg body weight with a maximum dose of 90 mg. 10% of total dose is given as an IV push over 2 minutes, which has to be supervised by a doctor experienced in stroke thrombolysis. Give remaining 90% of dose over 60 minutes by infusion. Patient must be continuously monitored prior to and during drug administration for at least 24 hours following administration. A dedicated stroke unit is always helpful in managing such patients. We need to stop the RTPA infusion if there is any risk of anaphylaxis, a systolic blood pressure which falls less than 100 millimeters of mercury, or there is rise in blood pressure which is sustained after 5 minutes, any GCS drop of more than 2 points, or any major systemic bleeding. Aspirin or any antiplatelet has to be withheld for 24 to 48 hours after onset. If the patient has not been thrombolyzed and the patient has presented to us late, that is more than 4.5 hours, we need to see if the patient has to be started on a single antiplatelet or a dual antiplatelet. It all depends on the NIHSS score. A patient carrying a high NIHSS score, that is more than 5, requires only a single antiplatelet, while the patient having a low NIHSS score, that is less than 5, should be started on a dual antiplatelet agent. Subsequently, the patient should be continuously evaluated to determine the ischemic mechanism. Any long-term antithrombotic therapy should be chosen depending on the stroke mechanism involved. To continue with the evaluation, if the patient is found to have an atrial fibrillation leading to the ischemic stroke, then the patient's CT scan has to be checked and then his blood pressure has to be seen. Any risk of symptomatic hemorrhage has to be kept in mind before starting the patient on any anticoagulant therapy. Generally, the dictum is, if the patient is having a large acute infarct or persistent hypertension without any major bleeding, only aspirin monotherapy has to be done, and any long-term anticoagulant has to be started 1 to 2 weeks once the patient is neurologically stable. If there is any major bleeding in the brain or systemic, then any antithrombotic therapy or aspirin should be withheld. If the patient is neurologically stable and there is a small infarct, that is less than 1/3 of the area involved, then the patient can be started on anticoagulant 24 to 48 hours after the admission. If the patient does not have any atrial fibrillation and there is any extracranial ICS stenosis which is leading to the stroke, then a carotid Doppler has to be done. And if the patient is planned for carotid end atherectomy, aspirin monotherapy has to be started. If the patient is planned for carotid artery stenosis, then patient should be started on DAPT. Again, according to the TOAST classification, depending on the small vessel, large vessel, or extracranial vertebral artery sclerosis, long-term antithrombotic therapy has to be started. The recommendation for statin therapy is we have to give high-intensity statin therapy regardless of the baseline cholesterol level. What I mean by high-intensity statin is atorvastatin 80 milligram, ezetimibe, or PCSK9 inhibitors. The duration has to be 90 days, and thereafter lower doses have to be used. The target LDL should be less than 70, and LDL should be monitored every 3 to 12 months. Among patients already taking statin at the time of onset of ischemic stroke, continuation of statin therapy during the acute period is reasonable. Clinical seizure should be treated with an anti-seizure drug. Prophylactic anti-seizure medication is not recommended, and continuous EEG monitoring in patients probably indicated in ICH patient, but not in an ischemic stroke patient. Patients with a change in mental status who are found to have electrocardiographic seizures on EEG should be always treated with anti-seizure drugs. So the take-home message is, time is brain. We need to diagnose a stroke patient and we need to act fast. Clinical stroke less than 4.5 hours, having an ischemic stroke on CT scan have to be thrombolized, and we need to keep this in mind and get a CT as fast as possible. If on CT brain we don't get an ICH, we need to proceed with thrombolysis. An aspect more than 7 and an NIHS score of 5 to 20 is ideal for a thrombolysis. We need to thrombolize, thrombolize, and thrombolize so that we can give a better life to the patient. Thank you.
So we have left with 3 minutes for questions. So I would like Dr. Zia kindly.
Congratulations, sir,
Thank
for
you.
a nice presentation for the management of acute ischemic stroke. Please share your experience with the use of thrombolytic therapy in acute ischemic stroke, and how many patients you used already, sir?
Sorry to say, in Bhagalpur, we could not thrombolize any stroke patients because by the time the patient turned up to us, it's already more than 4.5 hours. And once we shift the patient to a CT scan or an MRI diffusion weighted imaging, the time has already elapsed. But we used to thrombolize a lot of patients in our medical college during DM training, at least once a week. As I explained earlier, for a patient who are non-diabetic, for a patient 40 to 60 years of age, for a female patient, for MCA stroke with NIHS around 5 to 20, the results have been very good. Just 1 to 2 hours after thrombolysis, the patient NIHS has markedly improved, or the power has improved from maybe 2 to 4 and 5, and subsequent to discharge in 3 months, the MRS grading has improved from 4 to 1. There have been few cases of hemorrhage conversion, but symptomatic hemorrhage conversion leading to, again, any intervention has been very less. These symptomatic conversions were managed by FFP or blood transfusion. Lot of thrombolysis is happening in metros because, again, availability of CT scan and imaging, which is quite available. Patient is quite aware because of the media campaigns. is being advertised everywhere. And the moment the patient comes across having a weakness of one half of the body, they immediately reach to an ER where a CT is available. A stroke team is alerted immediately, and they act quite fast. Prior to the transformation or the transfer of the patient to the imaging, the already NIHS's and evaluation is done. So by the time the imaging is seen on the console, we already know the NIHS's, the clinical scenario, the risk, the past history. And then the patient is subsequently shifted to the stroke bed, where already the sisters, nurses, and the dedicated staff is alerted. The moment patient reaches there, we put a 2 central cannula and we start the thrombolysis.
Thank you, sir.
Sir, kind.
Sir, unless contraindicated, अगर हम थ्रोम्बोलाइज नहीं किए हैं तो एस्पिरिन देना है. अगर NIHS से ज़्यादा भी है, बड़ा स्ट्रोक भी है, तो भी एस्पिरिन देना है. सिर्फ एक कंडीशन में एस्पिरिन नहीं देते हैं, अगर हीमोरेजिक ट्रांसफॉर्मेशन इश्केमिक स्ट्रोक में बहुत ज़्यादा है, वो कुछ मास इफेक्ट कॉज कर रहा है, एंड क्लिनिकली मुझे लग रहा है कि एस्पिरिन ज़्यादा हार्म करेगा रादर देन एनी बेनिफिट देगा. अदरवाइज एस्पिरिन मोनोथेरेपी अर्ली ही शुरू कर देना है हम लोगों को. सर आईवी ही देना है. एल्टीप्लेस 1 घंटे का इन्फ्यूजन है, पर अब इंडिया में मोस्ट ऑफ द स्ट्रोक सेंटर्स टेनेक्टोप्लेस यूज़ कर रहे हैं बिकॉज वो चीपर पड़ता है. सर एक वाइल एल्टीप्लेस 50,000 का आता है, अगर उसमें भी 50 mg ही है, 2 वाइल तो एक पेशेंट को लगता ही है, उसमें 1 लाख रुपए तो खर्च हो ही गए अप्रॉक्स. उसके बाद भी आपको पेशेंट को काउंसिल करना होगा बहुत बार कि रिस्क ऑफ ब्लीडिंग है. टेनेक्टोप्लेस थोड़ा चीप आता है और 20 mg का वाइल आता है. 0.25 mg पर kg बॉडी वेट हमें देना है. तो सपोज 50, 55, 60 kg का पेशेंट है जो स्टैंडर्ड वेट है, उसमें एक वाइल में काम हो जाता है तो 22,000 का एक वाइल पड़ता है, तो पेशेंट को चीपर पड़ता है. प्रॉब्लम एक ही है टेनेक्टोप्लेस से सर कि अभी तक उसको FDA अप्रूवल नहीं मिला है, जबकि इंडिया में हम लोग रैम्पेंटली यूज़ कर रहे हैं.
Hello.
दोनों IV देना है, टेनेक्टोप्लेस सिंगल शॉट देना है, उसका कोई इन्फ्यूजन नहीं है.
I'm sorry for interruption, doctors. We have to move forward to the next talk. Thank you so much to our speaker for the wonderful talk.
Thank you.
I would like to request our next speaker, Dr. Sunil Agarwal, to please join us on the dais.
Welcome all of you. My topic is very under-recognized subject and disease, that is sleep. And we spend 1/3 of our life in sleep. And in US, before issuing a driving license, sleep study is mandatory, but India has no such type of sleep study before issuing driving license anywhere. So it is a matter of concern. My friend, he was professor, assistant professor in Betia, and during driving in morning, he go to morning from Patna to Betia for duty and dash in and that due to sleep. So it is a matter of concern. American Medical Journal of 28th November 23 shows obesity affects approximately 42% of US adults and 23% of Indian adults at the age of 15 to 43 years in India, and is associated with increased rates of type 2 diabetes, hypertension, cardiovascular disease, sleep disorder, osteoarthritis and premature death. अभी मेटाबॉलिक सिंड्रोम में स्लीप एपनिया भी ऐड हो गया है, अभी नया जहाँ आ रहा है ना. इन मेन विथ ए BMI of 30 to 39, cardiovascular event rate are 20.2 per 1,000 person per year, compared to 13.7 per 1,000 person per year in men. So BMI is very important. काम नहीं कर रहा है ये। ये तो हो गया इसका। तो मैं ही रुको 5 मिनट। नेक्स्ट करो। 60% of persons with BMI of more than 30 kg per meter square and 98% with BMI of 40, more than 40, have sleep apnea, which is largely unrecognized, which can be easily diagnosed by doing a sleep study performed in hospital as well as at home. Symptoms of sleep apnea include, next, yes, loud habitual snoring, witnessed apnea, nocturnal awakening, nocturnal frequent urination at night, unrefreshing sleep, morning headache, excessive daytime sleepiness, automobile or work related accident, decreased libido, impotence, irritability, memory loss, personality changes. Next. About 1/3 of all adults experience daytime sleepiness. Daytime sleep causes significant morbidity. It can result from insufficient sleep, primary sleep disorders such as sleep apnea or central disorder of sleep. Hypersomnolence or can be secondary to medication or use underlying medical or psychiatric illnesses. Next. Yes, the evaluation of daytime sleepiness involves a comprehensive history, conducting a focused examination and utilizing appropriate clinical testing. And when excessive daytime sleepiness is secondary to other causes, they should be identified and treated. And finally, that central disorder of hypersomnolence, that is narcolepsy, Klein-Levin syndrome, idiopathic hypersomnia, require a specialized pharmacological management. Next. Difficulty waking in the morning, rebound sleep on weekends and vacations with improvement in sleepiness, diagnosed by sleep log, diagnosis is insufficient sleep and treated by sleep education and behavioral modification. Obesity, snoring, hypertension, diagnosed by polysomnogram or home sleep test. Diagnosis is obstructive sleep apnea and the treatment is CPAP. Oral airway surgery, dental appliances, weight loss, and some exercises for upper airways. Cataplexy, hypogonagogic hallucination, sleep paralysis diagnosed by polysomnogram, and multiple sleep latency test. Diagnosis is narcolepsy treated by stimulants like modafinil, methylphenidate. REM sleep, suppressing antidepressant, that is venlafaxine. And the restless leg kicking movement during sleep, diagnosed by assessment for predisposing medical condition, that is iron deficiency or renal failure. Diagnosis is restless leg syndrome with or without periodic limb movements. Treatment of predisposing condition, pramipexole, gabapentin, etc. Next. Sedating medications, stimulant withdrawal, head trauma, systemic inflammation, Parkinson's disease and other neurodegenerative disorders, hypothyroidism, encephalopathy, diagnosed by thorough medical history and examination, including detailed neurological examination, treated by changed medication and treat underlying condition, consider stimulants. Treatment of excessive daytime sleepiness secondary to central disorder of hypersomnia is primarily pharmacologic with wakefulness promoting agents such as modafinil, stimulants such as methylphenidate, amphetamine and newer agents specifically diagnosed to improve wakefulness. Behavioral intervention can be useful adjunct to pharmacological treatment. The multiple sleep latency test is used to measure a patient's propensity to sleep during the day and can provide crucial evidence for diagnosing narcolepsy and some other cause of sleepiness. A home sleep test usually focuses on respiratory measures and is helpful in patients with OSA, obstructive sleep apnea. Evaluation of the patient with excessive daytime sleepiness. This is summary and this is chart. We can discuss in previous slide. We have to next. Thanks.
Sir, give your comments.
Thank you, Dr. Sunil, for your nice presentation regarding sleep. It's a very common disorder. I want to know which one is the most effective and drug of choice drug for sleep, in your opinion?
Modafinil, 200 milligram OD, we can start. Otherwise, so CPAP machine is the mainstay of the treatment. Do OSA, sleep study, and if needed, CPAP.
Have you used this modafinil in sleep
In
disorder?
few patients, but not very effective. Very mild disease may respond, but in severe apnea, not respond. CPAP is the, some person get exercise of the throat, tongue, neck muscle. They do exercise, but not so. Neck surgery, very tough. Head and neck muscle mass reducing surgery, but very difficult and not practically feasible. So the mainstay is the CPAP.
So, is there any question?
Thank you, sir, for your nice presentation. I just want to add a few more points. The most common thing, most common cause of the daytime sleepiness in our practice is basically the obstructive sleep apnea, as you told also. And as sir was telling about the modafinil and those drugs are only symptomatic managements, those drugs. We have to manage the obstructive sleep apnea nicely. And of course, the CPAP is the treatment of choice, although the compliance rate is worldwide only 50%. Nowadays, the other modalities like mandibular advancement techniques, dental appliances are also being used, but cost is the constraint, and again, it is difficult to use for the most of the patients. A few things is in the pipeline, just like pacemaker device, an electronic device is being tested. That is, the results are very good in the dogs. Human trials are still awaited. They put the machines in the buccal mucosa and the electrodes are placed in the pharyngeal muscles. And it is programmed in such a manner that, that when the patient sleeps, it gives impulse to the pharyngeal muscles and the tone of the pharyngeal muscle is increased so that the sleep apnea doesn't occur. So we hope that in next few years, these all will come and the treatment become more easy for the obstructive sleep apnea. And once the sleep apnea is better managed, all daytime symptoms are gone. Because the sleep architecture the whole night is well maintained and the patient sleeps nicely, so that there is nothing like daytime sleepiness.
Yes, pacemaker near the tongue. Near the tongue ko stimulate.
Thank you, Sunil. As usual, you were nice, precise, and to the point. And I entirely agree what you have said. But I would say another aspect of it. The person who is talking now has always slept for more than 1 hour in daytime, and if he doesn't sleep, and that is started not only in old days, it is started while I was in medical college, and that's very refreshing. Unless डॉक्टर साहब जो बोल रहे हैं स्लीप एपनिया वगैरह का प्रॉब्लम नहीं है, तो इट्स वंडरफुल टू एंजॉय डे टाइम स्लीप. इट री-energizes you. Thank you.
सही सर.
Hello.
Absolutely right. Absolutely right. Absolutely. Right.
Well, with respect to the time, we'll have to also move to the next one. Yes.
प्रिंसिपल साहब चले आए हैं, बहुत डिसिप्लिन मेंटेन करते हैं.
Thanks to our chairpersons and all our speakers of first session. Moving ahead, I would like to request our chairpersons for the next session. May I acknowledge the presence of our chairpersons, Dr. Subhash Kumar, if he is here, Dr. Binod Kumar, Dr. A.K. Pathak, Dr. Binod Dhareva, Dr. Imtiaz Bharti. I would like to request Dr. M.L. Maheshwari, Dr. P.K. Singh, and Dr. Devi Ram to please join us to chair the session. Dr. Maheshwari, Dr. P.K. Singh, and Dr. Devi Ram. I would like to request our chairpersons to please introduce our speaker, Dr. Richa Angek.
A very good morning to all of you. I am privileged to introduce Dr. Richa Angek, BDS, MDS. She is Associate Professor in Jawaharlal Nehru Medical College, BHAGALPUR. And she loves marathon. I hope she doesn't do marathon during her lecture. Only thing I would say, she is a worthy daughter of worthy father. You will be glad to know she is the worthy daughter of Professor Dr. D.P. Singh. Please, Dr. Richa, please start.
Good morning, everyone. It is an honor to stand between the esteemed chairpersons and the esteemed audience. Me, Dr. Richa Angek, I would speak on diabetes mellitus and oral and periodontal diseases. I'm associated with Jawaharlal Nehru Medical College, and I'm doing oral surgery also. This is a small definition of diabetes, which is a chronic metabolic disease characterized by elevated level of blood glucose, which leads over the time serious damage to heart, blood vessels, eyes, kidney, and nerves. Here I stand in front of you as a dentist and as an oral surgeon to give voice from my group to tell you, please add us to your group, because every patient entering to our clinic is either diabetic or hypertensive or has a cardiac anomaly or pathology, or every second patient says, ma'am, मैं तो खून पतला करने वाला दवाई लेता हूँ. So when patient comes to us, they generally come with a normal complaint of pain, difficulty in chewing, bad breath, and tooth loss. So diabetes can cause gum diseases, it can cause cavities, cracked lips, yeast infection, and slow healing. So there are various presentations with which the patient comes. They come with tongue anomalies, they have burning mouth syndrome, they have dental caries, they have taste anomalies, abnormalities, they have cracked lips and cracked tongue, they have halitosis, they have white thrush. And when we do a final diagnosis and do a case history evaluation, we find a common factor, that's diabetes. I would just go in a kiddish way. We all have, who have crossed 40, we have problem of food lodgement. And what we do, we go back home, brush, and even use a stick and take it out. There where the problem starts. Food lodgement, and there is a lot of deposits from our saliva which cause its hardening, and then it forms a plaque. Once a plaque is formed, it becomes a harbor for the growth of the microorganism. And what we are already, if we are diabetic, it becomes actually a lacuna where there is periodontal problem, the osteoclastic activity starts. As the osteoclastic activity starts, there is a pocket formation. Once the pocket forms, and then the whole vicious cycle starts. So we see there are bacterial infection, viral infection, and these, as we know, you would know more than me that infection causes rise in the blood sugar level, and these rise in the blood sugar level will in return cause periodontal disease. So here starts the vicious cycle. This is a whole complex thing. I'll just jot down that dental plaque leads to periodontitis. Periodontitis in return leads to release of inflammatory agents as much as it releases in other body parts. These inflammatory agents like interleukins and tumor necrosis factor, which causes insulin resistance, and then it causes hyperglycemia, and in return it increases the severity of periodontitis. So this is a bimodal cycle. I treat diabetes, you treat diabetes, I treat gum disease, the patient is healthy. And there is a study where if the patient is taking his anti-diabetic medicines on time and the oral hygiene is maintained, the HbA1c level is reduced by 0.316. Definitely it is not a drastic level, but yes, it is a small step in reducing the blood sugar level. So reducing the pro-inflammatory cytokines levels leads to improvement in the glycemic control. It improves the glycemic control. Apart from the periodontal diseases, there are oral thrush, which is also very common. These are the scrapable white lesions, and even stomatitis and angular cheilitis. There are non-candidal lesions like irritational fibroma, fissured tongue, traumatic ulcers. There are neurosensory disorders like you say there is diabetic neuropathy. Yes, we have neuropathies in oral cavity also. It could be primarily because of other primary lesions, and it could be secondary because of the diabetes also. Coming to salivary dysfunction, we have features of polyuria, polydipsia, and polyphasia. So because of, as there is dryness in the oral cavity, reduced salivary secretion, which increases dental, periodontal, and other problems. Now we come to a bit of bigger disease. This is a part of maxillofacial part. Now we finished the dental part, maxillofacial part. Patient has small dental cavity that leads to, we see here, there is small abscess in the teeth, which is easily neglected, and as the patient is medically compromised, the infection reaches to facial spaces, leading to bilateral submandibular, sublingual space infection, and what we call it as a Ludwig's angina. And as Ludwig's angina precipitates, we have to undergo surgical treatment, and patient admitted in hospital is again jeopardized because patient is diabetic and the healing is slowed down. And these patients, I tell you sir, it reports almost every day to our clinic. There are an array of patients with space infections. There are extreme complications due to diabetes like fasciitis, cavernous sinus thrombosis, leading to morbidity and mortality too. This is a case of necrotizing fasciitis where there is infection in the fascias, and that leads to infection and pressure in the airways, and we need to do emergency management to save the patient. Yes, cavernous sinus thrombosis is because of the dental and periodontal disease. Yes, sir, because we deal with the danger zone present in the upper mouth and the nose area. Why? Because these danger zones are connected through 3 emissary veins to cavernous sinus, which in turn will lead to extreme complication like cavernous sinus thrombosis. This can also go from the paranasal sinuses infection, sir. So there are very simple daily habits which can save us from bigger agony. What simple habit? brush twice. I am repeating something which is told every day in your television, but yes, brush twice, floss daily. Floss, I don't think most of us do, but flossing is important. Use mouthwash, because these are those, they have antibacterial agents which enter in those areas or periodontal areas where a brush do not reach. Go for a regular checkup. Just small things which I told, like calculus, plaque, which may further lead to redness of the gums. And most of my female patients who are diabetic for 10 to 15 years and have entered the menopausal age with other complications, they come with redness of gums, and all we have to do is to tell them to control the diabetes, and in return we also do scaling regularly and keep them on regular follow-up. So it is on with the mutual effort from the physician and an oral surgeon that we can deal with this. And without your guidance, definitely we cannot do, because we have surgical patients with diabetes. I would just like to present two cases of mine in which this is an X-ray of a 37-year-old man, and he has lost all his tooth. If you see, I know it is, if you see, there is no bone support. He is a 37-year-old man, sir, and I have 10 to 15 such cases who have aggressive periodontitis, and patient has early diabetes. And because of early diabetes, we had to remove his entire teeth here, and entire teeth had to be replaced by implants. And with the implants, we gave him this smile, sir. We took a consent from the patient to put his picture. So this is an example of how extreme diabetes and periodontitis can mix up and complicate the patient. And losing all teeth at the age of 37 is definitely a tragedy, sir. There is another thing, because any patient will come up with the age of 50, 60, we have to do implants, because yes, by nature the tooth is lost. All we have to know is, we say them, glycosylated hemoglobin, please get it checked, because unless that's in the normal range of 6 to 8, we will not operate you. So with the control of diabetes, we can easily do treatments like this, where patients are highly diabetic, they bring their diabetes level in control. We can give this beautiful smile with the latest interventions, sir. So I end up with, we should aware the patient, sir. We should aware the patient. We should understand. We as a dentist, we tell them, so please take your medicines properly. We refer back to you. We put the patient on regular follow-up. If the patient is not diabetic or patient has not known themselves to be diabetic, we diagnose our clinical signs and symptoms and we refer back. And then we give advice to our diabetic smoker patients to quit it. And vigorous oral treatment, either be bacterial or viral or fungal, and with a medicine follow-up, they can be maintained, sir. So I would, as I was entering, there were big placards of oral, of all these medical lesions which were related to, or maybe diabetes, which causes diabetic neuropathy, retinopathy, and there could be something called oral and maxillofacial diseases that could be in relation to diabetes, sir. So I am requesting for a small placard from an oral surgery group. This is a voice from maxillofacial surgeons, sir, that we are totally dependent on you, and we, unless the patient is healthy, we cannot treat them further. So I give my sincere thanks to BAPICON, EZAPICON, and the scientific session members and chairpersons to give me the opportunity to speak in front of you. Thank you.
I have got only one word to say. It has been just brilliant, excellent, and superb. I fully agree that apart from this nephropathy, retinopathy, and so many pathy, we need to take care of oral dental aspect as well. And there has been phenomenal improvement in the diagnostic and therapeutic aspect in dental nowadays. The days are gone when they used to take out the teeth, the Todwa doctor, that now they are saving it and they are doing just wonderful, as you have shown in your case. I would request other chairpersons for their comments and blessings.
Actually, the crux of successful management in a diabetic whether it be oral surgery or general surgery, is the proper management of blood glucose and side by side have an eye on all the comorbidities the patient may have. If these are looked upon, the outcome will be excellent. Thank you.
We can take one quick question.
No question. Just I want to compliment you that as you were introduced by Devi Ramsar, worthy daughter of worthy father. So you kept all the good things that Dr. D.P. Singh has taught us. It is with you also. Thank you. Thank you.
Thank you so much. I think I have way to go. I think when I take one step, he goes a story above, so I have a long way to go.
Hello. Thank you so much, Doctor. But we are moving to the next next session. Before that, I would request a group picture with the chairpersons and the speaker, the previous speakers. If you have Dr. Neeraj Saraf with us. All the previous speakers and the chairpersons who are present, we can take a quick group picture. I could see a proud dad taking pictures of proud daughter, so I request sir to please join. Dr. Singh, sir, please join kijiye. Thank you so much. With this, moving ahead, I would like to request our chairpersons, Dr. Raj Kamal Chaudhary, Dr. Bharat Bhushan, Dr. Kamran Khan, Dr. Brajkant Singh, Dr. Dharmendra, Dr. Rajesh, and Dr. Kumar Saurav to please join us as a chairperson for this session.
ठीक कर दीजिए, डिस्कनेक्ट हो गया है, पीछे से डिस्कनेक्ट। यहीं से हुआ होगा।
Our first speaker of this session, Dr. P.K. Singh. Over to you, sir.
And thank you, and thanks the team of organizing secretary and chairman scientific committee for inviting me to be here. My topic is preventing diabetic kidney disease. It is a very relevant topic these days, and at the outset I will like to make it known to all of you that diabetic kidney disease prevention is not possible at this juncture. It can be delayed, it can be retarded, but can't be prevented at all. Diabetic kidney disease is a medical catastrophe of universal dimension, is a presumptive diagnosis of kidney diseases caused by diabetes. Possibility of non-diabetic kidney disease in diabetic patients must be kept in mind. A pooled meta-analysis of 48 studies of about 5,000 patients had 3 to 82.9% of non-diabetic kidney diseases in diabetic patients. Depending on the territory and the different studies. Kidney biopsy is the gold standard for diagnosis of DKD, but this invasive approach is a real psychological burden on all DKD suspects. Seeking a non-invasive approach to aid DKD precise diagnosis is urgently needed. So pathogenesis of diabetic kidney disease, as it is not clear in the laptop here, it is a multi-organ complex system, and solution is likewise diverse. So what is the solution? Precise and effective translation of basic research into clinical application, use of multi-omics analysis, application of mathematical modules and models, and even artificial intelligence in the direction of personalized management plan for different subsets of DKD patients expected to fetch the best outcome, keeping in mind the common comorbidities. Pathogenesis. As the old concept of pathogenesis of DKD has been glomerulocentric. DKD is conventionally a glomerulocentric clinical problem with increased intraglomerular pressure, thickening of GBM due to abnormal turnover of and modification of extracellular matrix produced by endothelial cells and podocytes, due to podocyte injury, mesangial matrix expansion, loss of glomerular endothelial fenestrations, damaged glomerular barrier, albuminuria, which is the clinical mark of DKD. Hyperglycemia accelerates mesangial cell proliferation, by which excessive extracellular matrix is produced, resulting in glomerulosclerosis, glycosylation, and of protein matrix. That is the classical KW nodules on histopathology. Now comes the tubulopathy. This has, we have not taken care of the tubulopathy factor in diabetic kidney disease, but as a largest resident population in kidneys, it is very important. Currently, ongoing research has shifted the glomerulocentric paradigm to tubulopathy as the prime mover of DKD. Within a few months of hyperglycemia, there is tubular cell hypertrophy, increased tubular basement membrane width, and tubular atrophy. These changes precede the glomerular basement membrane width, or at least accompany them. Increased tubular basal membrane width and tubular atrophy, peritubular capillary rarefaction due to pericyte migration and conversion into myofibroblast. As all of us know, renal tubules have rich capillary plexus around it, and endothelial cells, for every 5 endothelial cells, there are 2 pericytes to support the framework. But जैसा कि होता है दूरबीन में 2 गले का फांस बन जाते हैं, these pericytes migrate and change into myofibroblast, leading to fibrosis of the kidneys. Interstitial fibrosis, non-functional tubular glomeruli. Actually, in one study, it was seen that glomeruli are okay, but they have no tubules because of that tubulopathy in 7% of all patients. Hyperglycemia may directly cause tubular necrosis, epithelial mesenchymal transition, ECM deposition. Vascular changes are there, inflammatory cell infiltration is all over the kidney. Finally, glomerular and tubulointerstitial changes coalesce into fibrosis. So, there is a revived pathogenesis of DKD in type 2 diabetes mellitus, beta cell failure, mitochondrial dysfunction, and less autophagic activity leads to insulin resistance. Hemodynamic changes and metabolic disorders, increased RAS activation, increased excretion of metabolic products, pro-inflammatory, pro-fibrotic, growth factors, and chemocytokines. Dysregulation of a number of intracellular cascades and deranged complement system. There is extra oxidative stress and inflammation and fibrosis is there. These factors are independent risk factors for accelerating DKD. This also mediates crosstalk among podocytes, mesenchyme, endothelium, and epithelium. Actually, every cell is involved in the repair of the onslaught caused by diabetes, but there is maladaptation of the reparative process leading to diabetic kidney disease. This is the schematic presentation of how DKD develops. Actually, due to prolonged hyperglycemia, there are advanced glycation in products, and these affect in the extracellular compartment and the intracellular compartment. In the intracellular compartment, it enters by the receptors specifically for this advanced glycation in products, that is called RAS, and through various channels it goes to the genes which respond aberrantly, releasing factors for cell growth, ECM production, inflammation, and angiogenesis. All these things lead to interstitial fibrosis and glomerulosclerosis. Cytosolic pathway is also there, leading to the same result. This is the electron microscopic and microscopic picture of DKD. Actually, afferent arterioles are dilated due to various chemicals produced during the course of diabetes, and efferents are constricted. There is mesangial expansion, GBM thickening, podocytes are hypertrophied with effacement of food process, and there is apoptosis. Albumin is released into the Bowman's capsule and in the urine, that is microalbuminuria, and pericytes are converted into myofibroblasts. There are T cells, macrophages all over, leading to diabetic kidney disease. So, this is the schematic presentation of time frame, how it goes. In 15 to 20 years, about 1/3 of patients will develop microalbuminuria. After 10 years, 1/3 of them will develop macroalbuminuria, and after 10 years, 1/3 of them will develop end-stage renal disease, and after that, every 5 years, 1/3 of those ESRD patients will be eliminated, not only due to ESRD, predominantly by other routes like cardiovascular accidents. There are different biomarkers in different stages. So, if we want to see all the things in one picture, DKD is developed from type 2 diabetes mellitus by conventional and traditional hemodynamic changes, metabolic disorders, but of late genetic risk factors have come to the foreplay, and there are familial aggregations of DKD, racial and ethnic differences are there. These have been come to fore by different studies like linkage analysis, candidate gene screen, genome-wide association studies, and epigenome-wide association studies. Acquired risk factors are there, very important. These are metabolic memory, epigenetic modification, environmental changes, lifestyle changes, oxidative stress, hypoxia, and chronic inflammation. So that is the story of the DKD development pathogenesis. While kidney damage follows a typical course in first 2 decades after the initial type 1 diabetes mellitus diagnosis, the clinical course of type 2 is less predictable. The heterogeneity of onset and progression of DKD is reflected in the lack of congruence among measures of glycemic control, degree of albuminuria, the rate of decline of kidney function, and long-term clinical outcomes. Inherited factors along with acquired factor of metabolic memory plays an intricate role in type 2 diabetes mellitus induced DKD. Of genetic factors, diabetes mellitus can be subdivided into 2 forms, monogenic and polygenic. Under monogenic, neonatal diabetes and MODY, and under polygenic, type 1 diabetes and type 2 diabetes. Type 2 diabetes mellitus induced DKD may not develop in even those with poor long-term glycemic control and lifestyle intervention. It is more likely to develop in those with a family history of hypertension and CVD risk. So genetic and acquired risk factors play the main role. Our understanding of genetic architecture underlying DKD has been evolving of late with different sequential milestone techniques like linkage analysis, candidate gene screening, genome-wide association studies, next generation sequencing technologies, and epigenome-wide association studies. Linkage analysis and candidate gene screening identified a few type 2 diabetes mellitus risk genes. These are calpain, transcription factor 7 like 2, peroxisome profoliter activated receptor gamma, insulin substrate receptor 1, AC, and others. Overall, high frequency of alleles, these alleles are in high frequency in DKD, but they have low to average effect for DKD predisposition. So it may be derived that their presence doesn't guarantee the development of DKD, but there can be co-association. Overall contribution of these approaches to the study of type 2 diabetes mellitus heritability remained underpowered. Next, a significant advance in the study of genetic predisposition to type 2 diabetes mellitus and complications was the use of GWAS, genome-wide association studies, extremely effective in identifying genetic loci that regulate the metabolic traits of type 2 diabetes mellitus and DKD. More than 100 genetic loci have been identified. GWAS has technical limitation. Latest newer NGS technique applies whole exome and genome sequencing, which will find detailed genetic structure of DKD. It is a comprehensive technology which not only takes care of genome but exome also, and in the cohort studies, how they will behave in a development of DKD, it will be very important, and we can predict more accurately by this study. So these are several biomarkers which have come to fore, how they affect the development of DKD. These are also indicated, but it is not possible to tell about these things in this short talk. Although majority of these loci or genes have been robustly associated with onset of DKD, they are unable to account for heritability of DKD. They predispose, but from one generation to another generation, diabetes mellitus is transferred, and one predisposition for DKD is also transferred from one generation to other generation. These are due to this heritable factor of DKD, and these are metabolic memory epigenetic structures. Intriguingly, epigenetic risk factor is recognized to be firmly linked to critical acquired factor in the pathogenesis of DKD metabolic memory, thanks to rapid advances in epigenome-wide association studies, EVAS. Metabolic memory, early glycemic environment that may cause long-term programming effects on retinopathy, nephropathy, and microvascular disease. Epigenetics is a study of heritable differences in gene expression, transcriptional changes without changing the DNA sequence, that is, change in phenotype without change in genotype. Three systems are involved due to hyperglycemic milieu, that is DNA methylation, histone modification, and RNA interference. High glucose levels have persistent inhibitory effects on repressive histone markers, whereas modulation of plasma histone deacetylase activity and inflammatory status are at least partially related to exercise effects in type 2 diabetes mellitus. Fresh evidence of epigenetic changes implies that original change in these markers might be due to the prior hyperglycemia. In DKD, modification of epigenetic status by metabolic memory and following microenvironmental changes play a critical role in albuminuria change, renal function decline, and even more complex outcomes and features. The features may be inherited through multiple generations. So early marriage and childbirth will be more benefiting a strategy in type 2 diabetes mellitus prone population. So DKD in clinic, how to delay and retard it. Much of the basic research in DKD has offered a multitude of findings that are expected to be translated into revealing etiological mechanisms, supporting non-invasive diagnosis, designing new strategies of DKD management. Yet these individual findings are still far from being able to serve as established clinical predictors that can counter the current recognition of glycemia, hyperlipidemia, obesity, aging, and other common complications of DKD. Therefore, providing a more comprehensive selection of factors for the diagnosis and management of DKD is priority in the clinics. DKD can be divided into 5 stages: hyperfiltration, silent phase, incipient phase, overt phase. I will just 2 minutes, 3 minutes. Overt phase and ESRD. So CKD in diabetics is NDKD, DKD, and mixed. So difficulty in making precise diagnosis and device management strategy without renal biopsy, to which patient and doctor can both loathe. Physicians will be more willing to consider and analyze clinical factors, family history, risk factors, onset, timing of albuminuria and retinopathy, anemia, parathyroid hormone levels. So DKD mixed population is here. If it is non-proteinuric, vascular changes will be there, and BP control and lipid lowering will act. But if it is glomerulopathy, then steroids and immunosuppressor will do. But in pure diabetic nephropathy, ACE, RB, SGLT2, and phenterone-like drugs will do well. So DKD management, satisfying management strategy must be personalized. Recent research reported that type 2 diabetes mellitus can be stratified into 5 different clusters based on 6 variables. This is very important. That is glutamate decarboxylase antibodies, age at diagnosis, BMI, HbA1c, and homeostatic model assessment, 2 estimates of beta cell function, and insulin resistance. Among 5 clusters, people most resistant to insulin had a higher risk to develop DKD.
Sorry for the interruption,
Yeah.
but we'll have to sum it up.
Current general consensus in management of diabetes, stringent metabolic control of glycemia, lipids, body weight, and augmenting RAS blockade. After a long gap of 30 years after the discovery of ACE inhibitors and late ARB, SGLT2 inhibitors, GLP-1 receptors, and phenterone are the breakthrough molecules. About SGLT2, everyone knows in every conference. GLP-1 receptor agonists, a type of incretin-based drug, act on pancreas, offer indirect immunoprotection by improving blood glucose, blood pressure, and body weight. Phenterone, a non-steroidal selective mineralocorticoid receptor antagonist, had a cardioprotective action along with lower risk of CKD progression in patients of CKD and type 2 diabetes mellitus. It has a more potent anti-inflammatory and anti-fibrotic effect than a steroidal mineralocorticoid receptor antagonist. These are landmark molecules and studies.
Hello.
So in summary, DKD is undoubtedly a worldwide medical catastrophe, high prevalence, multifactorial pathogenesis, and lack of effective strategies in the treatment and management. More attention is now paid to genetic factors and epigenetic modifications in DKD development. Emerging valuable tools are ready for constructing multiple bridges among translational, precision, and personalized medicine of DKD in clinic. Large-scale RCTs to validate identified biomarkers are urgently needed to prevent DKD. I will like to mention one slide, that is the strategy. So we put the clinical history, patient history, and clinical data, and combine it with different biomarkers from different DNA, RNA, protein, and metabolic studies, and pass it through a database, and module development and mode of that development, module development is validated, and we can predict the outcome. That is personalized management of DKD, which is the future of DKD management. Thank you.
Thank you so much. Thanks to our speaker. And due to time limitations, we'll have to move forward to the next talk.
Thank you, Dr. P.K. Singh, for excellent talk. P.K. Singh is my best friend. During internship, we worked together. Most of the speaker, P.K. हड़कंप मचा देता है, but Dr. P.K. Singh, P.K. शांत हो जाते हैं.
Thank you so much. Thank you for your lovely comments. And
next, this DKD or DNP is a common clinical manifestation. 45% of CKD is due to diabetes. So in diabetes, there is a structural and functional abnormality of the glomerulus. There is a thickening of the glomerular basement membrane that increases the size of the pore, and that causes loss of negative charge, and so there is a macroalbuminuria. There are so many clinical manifestations of DKD, A, B, C, D, E, F, G, H is the clinical manifestation of DKD. There is anemia, there is a bleeding tendency, there is a breathlessness, there is a dyslipidemia, there is a renal osteodystrophy, there is a hypertension, and this DKD or DNP is prevented by tight glycemic control, and insulin is the best choice. Next, there is a tight BP control, and
Hello.
in
Sorry
this
for the
condition,
interruption, doctor,
cilnidipine
but,
is a common manifestation. And anemia is also common manifestation. Dyslipidemia is also responsible in diabetic kidney disease. So this lipid-lowering therapy should be given to prevent this DKD complication. Thank you.
Actually,
I understand it's a very interesting topic. We can surely discuss it over a cup of coffee. Thank you so much. Moving to our next speaker, Dr. Himadri Shankar. And he is going to talk about renal biopsy in kidney diseases. Over to you, sir. You can start.
Yeah. So thank you everybody for giving me an opportunity to talk on one of the very important topics in nephrology, that is renal biopsy. So why do we need a renal biopsy? First one, to make a diagnosis, to plan treatment, to see the effects of drugs and how we have treated the patient and what is the effect. So renal biopsy is the gold standard of diagnosis of renal diseases. So, for the introduction, the first renal biopsy was done accidentally. They were actually doing a liver biopsy and they got a sample which was from the kidney. So that was the first renal biopsy, was an accidental biopsy. And through ages, through processes that the biopsy has evolved, we have got so many latest markers to diagnose kidney diseases. So the first biopsy was obtained accidentally, attempted at around 1940s. This led Alwal to the technique of to target the kidney directly using the aspiration biopsy needle that was first done by Iverson in the year 1944. And that was a landmark paper in 1951 that popularized the use of percutaneous renal biopsy that we use at present. So coming straight forward to the indications. What are the indications of doing a renal biopsy? First, we all know nephrotic syndrome except children. So we have to understand there are certain indications in children as well where we should go ahead with a renal biopsy. First, if the patient is having steroid resistant nephrotic syndrome, we've treated the child for 4 weeks with 2 gram prednisolone per kg body weight. Still, the patient is on remission, we have to do a biopsy or we have to plan for genetic tests or further. Second, if the patient, if the child has hypocomplementemia. Third, if the child has any other features like asymptomatic microscopic hematuria or any other, we suspect any genetic diseases, in those conditions, we should plan for a biopsy in case of children as well. Acute kidney failure without clear cause, chronic renal impairment, especially with proteinuria or hematuria, non-nephrotic proteinuria, microscopic hematuria, and if we suspect systemic diseases with abnormal function. So guiding principle should be whether biopsy findings would change the management or make a diagnosis, have some prognostic value. Biopsy of adults with nephrotic syndrome, that is very important to make the clear diagnosis, because that will help in the treatment. Repeated biopsy, we also need, sometimes we have to do a repeat biopsy. I have personally have done repeat biopsy in case of lupus nephritis, where there is a class change, where patients shift from class 3 to class 4 or class 4 to class 5. So in those cases, repeat biopsy is required. Corticosteroid dependent or resistant to exclude an alternative diagnosis like FSGS. We have to understand why biopsy is important and why knowing native kidney disease is important. Even if we are planning a transplant, there are certain diseases that reoccur post-transplant, like an FSGS. FSGS can have a very early recurrence. Even the patient can on table have proteinuria post-transplant. So we have to understand why doing a kidney biopsy or knowing the kidney disease is important. Like IgA nephropathy, it has a recurrence of around 50%. Lupus nephritis has a recurrence of less than 1%. So native kidney disease is very important. Pediatricians, as I told, when they have, for children, they have atypical features like low complement, microscopic hematuria. Yeah, so coming on to acute kidney disease. 4% of AKI is generally secondary to glomerulonephritis or acute interstitial nephritis. Acute interstitial nephritis we have seen in so many cases where the patient takes NSAIDs or any drug-induced. So patient with hemodynamically mediated AKI do not need a biopsy unless the cause of AKI is unclear. We have ruled out other causes like acute tubular necrosis, obstruction, or pre-renal causes, and still the AKI is persistent despite the reversible of cause, or if the serum creatinine does not return to the baseline within 7 to 14 days of injury onset. In those cases, we should go ahead with renal biopsy for a patient who is present with acute kidney injury. Proteinuria, so we all know this is the most important guiding factor and leading causes of doing a renal biopsy, that is proteinuria more than 1 gram as measured on multiple visits with no clear comorbidities. We always have to know the gold standard test for proteinuria is 24-hour urine protein. This is the gold standard test and should be done for all the patients whom we are planning to do a renal biopsy. Proteinuria more than 3 grams per day in the absence of diabetes. Rapid increase in proteinuria even with diabetes. So here the point we have to understand is even if the patient is diabetic, there are certain indications where we should plan a renal biopsy for a patient who's diabetic for a long time. If there is absence of signs like retinopathy, or if the patient doesn't follow the proper timeline of a diabetic nephropathy, he has rapid increase in proteinuria or rapid decline in renal function. In such cases, we should consider biopsy for diabetics as well. One of the diabetic biopsy I did in Bhagalpur, we got amyloidosis for a patient who presented with proteinuria more than 10 grams. He was a diabetic for 10 years. So that was, that is the message, that we should consider biopsy even in cases who are diabetics. So patients with known systemic diseases such as systemic vasculitis, anti-GBM disease, or an SLE are often biopsied. Lupus, we all know 5 stages. We have to know the stages. We have to know whether lesions are active or chronic. That will help us in guiding the treatment. Diabetic patient, as I already mentioned, we should consider with the rapid onset nephrotic syndrome, a short duration of diabetes, possibly with significant hematuria or systemic disease, a biopsy is indicated. Less benefit in patients with relatively low level proteinuria and normal renal function. So low level proteinuria may precede the nephrotic syndrome except minimal change disease. So the threshold for biopsy is lowered as the proteinuria increases. Microscopic hematuria, very important, isolated hematuria, especially in those aged over 40 to 50 years. First, they need a urological diagnostic workup. And biopsies in this setting most often reveal IgA nephropathy. Because in IgA nephropathy, 50% of the patient present with asymptomatic microscopic hematuria. Please remember, so 50% of the patients, they will be presenting with asymptomatic microscopic hematuria, and almost 5% of the patient in IgA present with nephrotic syndrome. So that is also a point to be remembered. Transplant kidneys, what we used to do, I'm from Rabindranath Tagore, Kolkata. So what we used to do when there was a sudden rise in creatinine, or the creatinine was like more than 25% from the baseline, we used to do biopsies, because initially there is delayed graft function, there could be rejection, that is antibody-mediated rejection or cell-mediated rejection, because both of them have different line of treatment. So we have to be very cautious, and we used to plan when patient had these features. So coming on to what are the contraindications. So absolute contraindications, this small kidneys. Kidneys have actually, most of the patients, they present late to us. By the time they present, the kidney is already small, shrunk, so there is no point of doing a kidney biopsy. Abnormal coagulopathy, uncontrolled hypertension. So what I follow is, when the BP is less than 150 or 160, we do a renal biopsy. Relative contraindications are solitary kidney, uncooperative patient, unable to lie down flat on bed, abnormal anatomy including cysts, patient is suffering from autosomal dominant polycystic kidney disease, so we should not do a renal biopsy in those cases. And infection, especially acute pyelonephritis. So pre-procedure, these are the safety conditions, or generally what we follow. Hemoglobin should be more than 9, platelet count should be more than 1 lakh, prothrombin time and activated partial thromboplastin time should be less than 1.2 of control, blood pressure preferably less than 160/90, and sterile urine. So we should all do a urine culture before we plan for a renal biopsy. Technique, for most important, before any procedure, consent should be taken before the procedure, counseling should be offered. We have to explain the patients that the procedure we are doing and what are the associated complications. Most common complication what I have seen is bleeding, pain, hematoma. We have had one nephrectomy in our hospital, that was in Kolkata, RN Tagore, where one of the patient had to go undergo nephrectomy because of severe bleeding which could not be controlled. So this was only one incident that I remember in past 10 years. That was in our institute. Either kidney may be biopsied, but left kidney is usually more convenient as it is usually lower so to access the pole, and it is much easier. Patient lies prone, optimum entry site with ultrasound is determined, aiming for the lower port through the cortex. Kidney biopsy is usually performed in prone position. So I'll show, this is a automatic spring grid biopsy gun. Biopsy needle is introduced at an angle of approximately 70 degrees to the skin and is guided by continuous ultrasound. Here we can see the operator shown wearing a surgical gown. This is not strictly necessary, but we have to follow. Other biopsy accesses, what we generally use is laparoscopic kidney biopsy. And the indications for this is failed percutaneous biopsy, chronic anticoagulation state, patient is morbidly obese, solitary kidney, or multiple cysts, kidney artery aneurysm, or uncontrolled hypertension. The advantages of doing this procedure is it is done on outdoor basis, under vision, wound infection is less, adequate hemostasis achieved, safe and reliable, and if required, open procedure can be made. Transplant biopsies, kidneys are superficial, so it is much more easier as compared to a native kidney biopsy. Complications. So the most common complications, bleeding, hematoma, that is 75%, subscapular bleed less than 1%, retroperitoneal bleed 5 to 10%, microscopic or gross hematuria. This is the most common complication. Other than that, AVF formation less than 5%, pain, infection, nephrectomy. So adequacy of tissue sampling, what we need, the minimum number of glomeruli that we need for adequate diagnosis. For glomerular lesions, it's 5. For tubular cystatial lesions, 6 to 10. And for transplant kidney, 7. These are the generally stains that we use. So I would like to discuss some practical points. I mean, the biopsies that we have done at our center. Just to show you some cases, like this was the case where with patient's permission, where the patient presented to us with a creatinine of 8.3. We can see this is a 29-year-old male who presented to us with a creatinine of 8.3. He was offered hemodialysis outside, but we didn't go for dialysis. We waited. He had UTI. So we treated the UTI. After treating the UTI, we realized the creatinine is coming down. It was around 4. So we did a renal biopsy for this patient. What we found was the patient had a proliferative IgA nephropathy associated with crescents. So this was a crescentic type of picture. We treated the patient with pulse olumedrol for 3 doses, and then we kept him on steroids for 3 months, plus other measures like the patient was on ARBs and low salt diet, and all that was followed for low protein diet. Everything was followed. You can see the difference. After 3 months, his creatinine went down to 1.1. And let me tell you, the patient didn't receive any dialysis. Nothing was done except biopsy and treated for IgA nephropathy. Case 2. This was a male who was being treated outside he had nephrotic syndrome. He was started on steroids, but was not responding. So the patient presented to us with, he was a known hypertensive, presented with swelling of lower limbs, shortness of breath, reduced urine output, and frothy urine. He had history of NSAIDs. He also received steroids in the past. His ANA was positive. So I was suspecting lupus nephritis, probably males lupus, relatively less incidence. So we did a biopsy, and we found out that the patient has features of suggestive of diffuse proliferative lupus nephritis class 4 with moderate activity index. The patient was treated with pulse olumedrol and urolupus regimen. We gave him 6 doses of cyclophosphamide. The patient responded. At present, his proteinuria is less than 100. He's stable. He does not have any edema, and he's stable at present. So this was a case of female who presented to us with lower limb swelling, facial puffiness, generalized weakness. Creatinine was normal, renal function was normal, and urine showed proteinuria 2 plus 12 to 15 RBCs. Her ANA was positive. So we did a kidney biopsy. Kidney biopsy showed feature of immune complex mediated proliferative exudative glomerulonephritis. So correlating with the history of ANA positivity and C3, C4 levels well known, so they suspected a class 4 lupus nephritis. But the point here is she also had fever 1 week before we did a biopsy. So we didn't start her on steroids. We kept her on antibiotics and gave her a low dose of steroids. But surprisingly, her proteinuria, she responded, and we did a dsDNA which was negative. So basically this was a case of infection-related glomerulonephritis. Case 4, this was an interesting case which I have also presented in the APA, where one of the patients who was advised to consume fish gallbladder for health benefits. This was given by a quack, advised by a quack, and the patient took fish gallbladder. He had AKI. Patient presented to us with a creatinine of 13. So we did 3 sessions of hemodialysis, and to know the cause, I did a kidney biopsy, and it showed normal glomeruli with tubular injury with mild interstitial inflammation. That was consistent with tubulointerstitial nephritis. So this was in related to the raw gallbladder that he had taken. Patient recovered. At present, he is dialysis free and stable.
Just a gentle reminder, we have last 1 minute.
Yeah. So I'll finish it fast. This was a case of postpartum sepsis with AKI. Patient presented to us with a creatinine of 3.9. Outside patient was advised to do a AV fistula and undergo hemodialysis. So we did a biopsy for this patient and was found to have patchy cortical necrosis. I told her to wait, and we treated her as per the AKI guidelines. We treated her. At present, the patient is stable, does not require any dialysis. So this was just to show the importance of renal biopsy in our setup. What we have done, we have till now we have performed almost 100 renal biopsies. This was the demographic: male 34, female 66. What we found was primary glomerular disease constituted to about 80%, and secondary glomerular disease constituted to about 20% cases in our setup. The most common disease what we found was IgA nephropathy, that was in 16 patients, followed by infection-related glomerulonephritis, minimal change disease, diabetic nephropathy, lupus nephritis, MPGN, C3GN, amyloidosis, and CKD. So most common primary glomerular disease was IgA, and most common secondary glomerular disease was lupus nephritis. This is how we do a biopsy. This is my, so this is my last slide. where this patient who presented to us, she was in a very critical stage. She presented to us with a creatinine of 17, severe metabolic acidosis, bicarb of 1. We treated her, I dialyzed her for almost 4 days continuously. She recovered, and I counseled the mother for a transplant. Initially she was apprehensive, but later they agreed, and this patient is transplanted. This was our first transplant. We counseled the patient. We sent her, I sent her directly to Delhi, where she undergone a live renal transplant, and at present the patient is very much stable. So the message is kidney transplant is the best form of treatment for patients who having end-stage renal disease. And renal biopsy helps us a lot in any renal disease if we don't know the cause. Thank you. Thank you so much.
Thank you to our speaker. As we have only 1 minute for the comments.
Any questions from the audience?
One quick question, please. Oh, there are no questions.
If not, I will ask a question. I'm into rheumatology, and you told about your experiences of lupus. So I just want to know any experiences of lupus with type 1 diabetes.
No, sir. I haven't seen any case up till now, sir.
Okay,
I've done almost 9. I've diagnosed here, but none of them were diabetic, sir.
Just a piece of advice, don't feel offended.
Yes, sir.
Last slide you saw, I think you should protect the individuality of the patient.
Sir, that was with patient's permission, sir.
Okay, thank you.
Okay.
Thank you so much. Thanks to our chairpersons for chairing this session and our speakers as well. We can take one group picture. Okay, we are taking a picture at the outside of the hall also. I would like to request our next chairpersons for the session, Dr. P.K. Sinha. Is he here? Dr. Anjum Parvez, Dr. Birendra Kumar. I request our chairperson to please join us for the next session. I would like to request Dr. Deviram to please be the chairperson for this session, and I request our first speaker for this session, Dr. Sumit Shankar, to please join us on the dais. He is going to talk about antiplatelets in ACS. We have Dr. Ashish with us to chair the session. Please start the presentation, please.
Okay. Good morning, everyone. I think we'll skip the introduction. I have no disclosures. So, topic is antiplatelets in ACS. So, platelet adhesion, activation, aggregation, and plaque rupture or erosion are the major determinants of arterial thrombosis leading to ACS. We all know this. So antiplatelet therapy, which targets pathway of platelet activation and aggregation, is pivotal in both acute treatment and long-term secondary prevention of ischemic events in patients with ACS. Dual antiplatelet therapy with a combination of aspirin should be the treatment of choice in patients with ACS, and drug selection should be based on contraindications and individual patient characteristics. So these are the just basic brief introduction. These are the various trials through which antiplatelets have matured over time. What is the evolving paradigm? There is, on one side is death and major disabilities, whereas the other spectrum is cost of the drug, ease of use, duration of therapy, and bleeding as well as ischemic endpoints. This is the ACS spectrum, which includes ACS, that is abnormal ECG, clinical context, and stable patient. So whenever there is a high-risk patient, STEMI or very high-risk N-STEMI, so you can go for immediate angiography plus PCI. Or fibrinolysis if PCI is not available. The second line is antithrombotic therapy, which includes aspirin and P2Y12 inhibitors and anticoagulants, followed by staged PCI if at all required, PCI or CABG, and intravascular imaging or intravascular physiology. And last line, which is the very important, which should be followed in all, that is secondary prevention, which includes antithrombotic therapy, lipid lowering drugs, smoking cessation, cardiac rehabilitation, risk factor management, and psychosocial consideration. So what is the rationale of using antiplatelet drugs? It reduces thrombus burden and flow obstruction, it reduces peri-procedural damage, and it prevents stent thrombosis. This is a picture demonstrating the pathways through which antiplatelets act, that is P2Y12, GP2B3A inhibitors, and thromboxane A2 inhibitors. The other is factor 10A inhibitors, which includes fondaparinol, heparin, equiparinol. Okay, coming to the guidelines, this is the latest 2023 guidelines of ESC. We all know what is the loading dose of aspirin, that is 150 to 300 mg loading dose, followed by 75 to 100 milligram OD maintenance dose. There is no dose adjustment for CKD patients for aspirin. The second line drugs, that is P2Y12 inhibitors, the clopidogrel, what is the loading dose? We all know it is 300 to 600 mg, followed by a maintenance dose of 75 mg OD. Prasugrel should be given at a loading dose of 60 milligram orally, followed by a maintenance dose of 10 milligram OD, which should be reduced to 5 milligram OD if the patient is more than 75 years of age or has a weight of less than 60 kgs. Ticagrelor is very commonly used these days, which is given at a loading dose of 180 mg, followed by a maintenance dose of 90 mg BD. No dose adjustment is required for CKD patients. Cangrelor is very rarely used. The other class of drugs is GP2B3A inhibitors, which is eptifibatide and tirofiban. Tirofiban is commonly available and is used at a bolus dose of 25 mics per kg over 3 minutes, followed by an infusion of 0.15 mics per kg per minute for up to 18 hours. So these are the dosing regimens. So the three commonly used antiplatelet drugs, that is ticagrelor, prasugrel, and clopidogrel. P2Y12 inhibition is reversible in ticagrelor, whereas it is irreversible in the other two. Duration of effect is 3 to 4 days. On an average, you can take it as 5 days. So it can be used in all ACS patients. So how do you personalize this antiplatelet strategy after PCI? So you have to look at variable features, that is clinical variables, which includes bleeding, anemia, prior platelet count, prior stroke, liver disease, malignancies, and procedural features, that is like which access you have taken, radial or femoral or antiplatelet or anticoagulation given before the PCI, and various scores. The second point is platelet responsiveness. So where you do testing of the platelet function. And third is ischemic risk, which includes clinical variables, procedural features like multivessel disease or CTO or a bifurcation lesion, and various scores such as TIMI and Gray scores. So what is an ideal antiplatelet? It should have a fast onset. It should be superior antiplatelet action, low resistance, less drug-drug interaction, rapid offset, proven mortality reduction, and low bleeding risk. Again, coming to the recommendations of antiplatelets in ACS, this is 2023 guidelines. Aspirin is recommended for all patients to give at loading dose of 150 to 300, followed by a maintenance dose of 75 to 100 mg. 150 mg is not required, 75 mg OD maintenance dose is enough. Second line, in all ACS patients, a P2Y12 inhibitor is recommended in addition to aspirin, given as an initial loading dose followed by maintenance dose of 12 months. This is unless there is a high bleeding risk. The class 1, it should be followed. The other thing is class 1 is proton pump inhibitors, which you give in combination of a DAPT, that is dual antiplatelet therapy, in high risk of gastrointestinal bleeding. The other class 1B recommendation is prasugrel. So prasugrel is recommended P2Y12 inhibitor at a loading dose already we have described. 1B again is ticagrelor. 1C, clopidogrel is 1C, not 1A, 1B. It is 1C. Clopidogrel at a loading dose already described, 300 to 600. And if a patient is undergoing CABG, stop DAPT, but restart DAPT even in a post-CABG patient immediately after the surgery. So even if the patient is undergoing CABG, you should restart DAPT and continue for at least 12 months. Prasugrel should be preferred on above ticagrelor for ACS patients who proceed to PCI. So prasugrel is the drug of choice in PCI. GP2B is considered only and only when there is evidence of no reflow or thrombotic complication during PCI. If you are doing a primary PCI and there is a complication, you have put a stent and there is no reflow, that is the blood does not cross the stent. Only and only then you use a GP2B3A inhibitors, otherwise it is not required. That is also class 2A recommendation. Class 2B recommendation, P2Y12 receptor naive patients undergoing PCI, cangrelor may be considered. Again, 2B, no need to do that. In order, older ACS patients, clopidogrel as P2Y12 inhibitors may be considered. So only consideration in ACS patients where you want to give clopidogrel is older patients or high bleeding risk patients. Pre-treatment with a P2Y12 inhibitors is not required. What we mean by pre-treatment is before angioplasty or before a PCI. Pre-treatment with P2Y12 inhibitors may not be considered in NSTEMI, who are not considered to undergo early invasive strategy and do not have high bleeding risk, class 2B. Now, what is class 3 is pre-treatment with GP2B3 inhibitors is not recommended. Like I already told, it is class 3, do not give GP2B3 inhibitors in ACS patients. This is one, these are multiple trials which tells us the difference between ticagrelor and clopidogrel. I'll not go into the details, but uniform unguided de-escalation DAPT strategy switching from ticagrelor to clopidogrel was superior to ticagrelor based continuing DAPT strategies. The other trial is the exam trial, which shows that in chronic maintenance period after PCI, clopidogrel will be superior to aspirin in terms of patient orientation composite outcomes. These are just various trials, these are not guidelines. So how do you shorten DAPT? The problem with DAPT is dual antiplatelet therapy, it can lead to bleeding. So you have to maintain a balance between a thrombotic risk and the bleeding risk. So whenever there is high thrombotic risk, with low bleeding risk, you can continue DAPT. That is dual antiplatelet therapy in a high risk patient can be given for more than 12 months. But similarly, if there is low thrombotic risk and high bleeding risk, that is the last box, reduce DAPT to 1 month to 3 months only. Whenever a very elderly, thin, fragile patient, high bleeding risk, previous history of bleed, reduce dual antiplatelet therapy to 1 to 3 months only. And on top of that, do a P2Y12 inhibitor de-escalation. I will explain what de-escalation means. This is again a trial of clopidogrel versus ticagrelor versus prasugrel. So for elderly NSTEMI ACS patients, clopidogrel is favorable alternative to ticagrelor. Already told, elderly patient, you can prefer clopidogrel. This is a diagram showing the bleeding and the ischemic events versus bleeding events. So you can see the ischemic events is highest after the procedure for a period of 1 month. Thereafter, it declines and plateaus. And bleeding as well is also highest in the initial phases. So there are two strategies. One is escalation, the other is de-escalation. So escalation means you start with clopidogrel. If it is not effective, you switch to a more potent P2Y12 inhibitor, which is either ticagrelor or prasugrel. And the loading doses and maintenance doses have already been explained. And de-escalation. De-escalation means whenever the patient is having a very high bleeding risk or has had a bleeding event or a need for any oral anticoagulant, patient is having AF, has developed permanent AF or what sort, there is a clot, then you need to give anticoagulant. So what will you do there? You have to de-escalate. That is, come down from prasugrel to clopidogrel, from ticagrelor to clopidogrel. Again, guidelines, that is ESC guidelines. Patients who are event-free after 3 to 6 months of DAPT, who are not at high risk of high ischemic risk, single antiplatelet should be considered. So de-escalation of P2Y12 inhibitor treatment may be considered as an alternative to DAPT strategy to reduce bleeding risk. This is class 2B, should not be followed routinely. And the places, discontinuing of antiplatelet treatment in patients treated with OAC is recommended after 12 months. So whenever the patient is receiving oral anticoagulants, you can discontinue DAPT. So adding a second antithrombotic agent to aspirin for extending long-term secondary prevention should be considered in patients with high ischemic risk without high bleeding risk. So everywhere it is a balance between ischemia and bleeding. This is a class 2A recommendation. Now, since I have told many times bleeding risk, so what is this increased bleeding risk? So increased bleeding risk is whenever there is need of oral anticoagulant on top of a DAPT. They are at automatically high increased bleeding risk. The other one is age more than 75, frailty already told, hemoglobin less than 11, CKD, very important factor. The other thing is body weight, that is less than 60 kgs. A lot of our patients are less than 60 kgs. Hospitalization for bleeding within last 1 year, prior stroke or patient belonging to Dr. Neeraj Saraf, that is bleed, and regular need of NSAIDs. The guidelines. So whenever there is a CHADVA score, this is for AF, patient having AF. CHADVA score of more than equal to 1 in men and more than equal to 2 in female. After 1 week of triple antithrombotic therapy following ACS event, dual antithrombotic therapy using a NOAC at the recommended dose for stroke prevention and a single oral antiplatelet is considered for up to 12 months. So give dual antiplatelet only for 1 week with a NOAC. Do not continue dual antiplatelets beyond 1 week. I'll explain the flowchart later on. So during PCI, you can give, PCI means heparin. Most of us, we use heparin during the angioplasty. So if the patient is on NOAC, you can give heparin. If the patient is on warfarin or any vitamin K antagonist, if the PTINR is less than 2.5, only then you give heparin. That is class 1 recommendation. Class 2A is maintain a PTINR of 2 to 2.5, not beyond that. Do not target 3 or more than 3. Rivaroxaban can also be used, but dose reduction to 15 mg OD. Dabigatran can also be used, but dose reduction to 150 mg BD, not 110 BD, not 150 BD. And always try to come down to a single antiplatelet agent. So these are all class 2A recommendations. Class 3 is, already I have told, do not use prasugrel or ticagrelor in combination with oral anticoagulant. Never use prasugrel or ticagrelor. The same in a pictorial representation, like I told, for 1 week triple therapy, followed by dual therapy, followed by monotherapy with a NOAC or a oral anticoagulant beyond 12 months. These are all chronic syndromes. It is not included in my study, but anyways, I'll talk about it. Addition of second drug in high risk or moderate ischemic risk is recommended. So what is this high risk in chronic stable angina? That is multi-vessel disease, diabetes, recurrent MI, peripheral vascular disease, and the most commonly CKD. Guidelines, I will not talk about it. Okay, these are all composite of multiple trials, which includes, which tells us that aspirin is better than clopidogrel for maintenance therapy. Aspirin, you can see in the graph, aspirin favors reducing all-cause mortality.
Just a gentle reminder, we have 1 minute.
Yes, I'm about to finish. What is this Minoca? That is in MI in a normal coronary artery. There is no consensus regarding this. That is the incidence of MACE was similar to clopidogrel, for clopidogrel and ticagrelor So you can use either of them. Similarly, in the meta-analysis, de-escalation strategy of DAPT after ACS was associated with a lower number of clinically relevant bleeding with no association of increased ischemic events. So de-escalation can be tried in all patients. This is my final slide. Just to brief up the approach, all of us know this, that is STEMI. You should go for a primary PCI. That is class 1 recommendation. There is no questions, no doubt about it. So you can use unfractionated heparin in that. Okay, non-invasive strategies already told. Prasugrel should be preferred over ticagrelor. Clopidogrel is used only in elderly patients or very high-risk bleeding patients. If you are proceeding to PCI, class 2A, prasugrel preferred over ticagrelor, followed by dual antiplatelet therapy, which includes aspirin plus a P2Y12 inhibitor, class 1, followed by aspirin alone, class 1, after 1 year. Thank you.
Thank you very much, Dr. Sumit Sankar. Only 1.5 comments. We had one Sankar, हम लोग धन्य थे, फिर आए दूसरे शंकर, हम लोग और भी धन्य हो गए, अब तीसरे शंकर से हम लोग महाशंकर हो गए। तीनों ही शंकर को प्रणाम और धन्यवाद। A quick word to the audience. Get used to one or the other drug, one or to another regime. Don't keep changing your drugs after every other CME. Write only those things you know better, side effects, doses, and etc. and etc. Thank you.
I'll just cut short in 1 minute. Thank you. It was a great slide. I have two practical situations. Let's take home message from these guidelines like 1A, 1B, 1C is very confusing to a lot of people. So I'll give a scenario, a patient with triple vessel disease, all 3 vessels are blocked and they are all critically blocked. We have done angioplasty on 2 vessels. 1 vessel we could not do because it is a small vessel, we cannot do it. Now should we continue the dual antiplatelet for lifelong or follow the guideline for 12 months? Very simple question. Same scenario, triple vessel disease with atrial fibrillation. Now what to do? Should we continue according to guideline only for 12 months or should we continue for lifetime?
Sir, if the patient is having AF, yes, you can continue dual antiplatelet therapy with oral anticoagulant for 1 month, followed by oral anticoagulation and a single antiplatelet therapy for 1 year, followed by oral anticoagulant alone after 1 year. That is clear. There is no question about it. But regarding dual antiplatelet, beyond 1 year, you have to calculate the risk score again. If the bleeding risk is high, no need to give dual antiplatelet. But if, like your case, sir, the triple vessel disease, 2 vessels are done, long stents probably, and 1 stent, 1 vessel is left. So in that case, probably if the bleeding is risk is low, we can continue dual antiplatelet therapy for a longer duration.
The extension
your comments, sir, any regarding this?
Extension to this question, sir. If you are using antiplatelet along with the newer anticoagulant, which antiplatelet you would like to use between aspirin and clopidogrel, and why?
Like I told, sir, do not use ticagrelor or prasugrel. You can use aspirin and clopidogrel only. Do not use either of the two, prasugrel or ticagrelor. Continue with aspirin and an oral anticoagulant followed by an oral anticoagulant alone.
Thank you so much.
I think it's a clopidogrel to be used whenever you are using newer anticoagulant. Do not use aspirin. Even if you are allowed to use aspirin and clopidogrel, but clopidogrel has an edge over aspirin while using newer anticoagulant. And one more, rather than question, I would like, because ticagrelor is taking place and it's almost replacing clopidogrel in ACS patient not undergoing PTCA. Those patients who had witnessed ACS and in a city where there is no cath lab or cath lab enabled hospitals are not there, we are using ticagrelor there. In those patients, a few things I would like to mention that do not use this ticagrelor in any patient having brady or tachy of any kind, because ticagrelor has an inherent tendency to cause a significant number of patients going into bradyarrhythmia or a tachyarrhythmia of different kind. Many of patients will land in CHB. So Sumit, congratulations. It was a wonderful talk on antiplatelet, and I would like to request sir to conclude that.
Thank you so much. With this, we are done with this talk. Thank you to our chairpersons for this wonderful insights and comments, and thanks to our speaker.
Wonderful and wonderful.
I request our speaker to please proceed for the felicitation which is going on outside this hall. And moving to the next session, Dr. Ajay Sinha's talk had been shifted to the hall A. It's already done. So we are moving to the next session on respiratory. And for that, I request our chairpersons, Dr. Archana Malik, to please join us on the stage. I would like to acknowledge the presence of our other two chairpersons, Professor Dr. D.P. Singh and Dr. Devendu Bhushan. I request Dr. Archana to please join us on the stage. Other chairpersons will join shortly. Can we have the presentation for the first speaker, Dr. Gagan Gunjan? I request our chairperson to please introduce our first speaker, Dr. Gagan Gunjan.
Good morning, everyone. Dr. Gagan Gunjan is currently working as an assistant professor in general medicine, RIMS Ranchi. He has done various publications and wrote editor in several books and journals. He is active in teaching Eugen PG in his institute, and he has a special interest in cardiometabolic disease and emergency medicine. Thank you, sir.
Dr. Gagan Gunjan has been a very dynamic API member and very good orator, speaker for last few years, and you can see him in every forum. Wherever there is CME, Dr. Gagan Gunjan is there. And he is the student of this medical college. Welcome, Dr. Gagan, and give your deliberation. And the topic is very important clinical topic, that is clinical approach to acute breathlessness, and that we often encounter in our clinical practice or in the emergency room. Anybody presenting with breathlessness and how to deal with, how to approach it. Over to Dr. Gagan.
Thank you, sir, for your very, very kind words. A very, very good morning to all of you, to the chairpersons and all members in the house. I have chosen this topic. This is quite fascinating to me. I think it is fascinating to everyone, right from the days of internship to the entire clinical practice. So what do we mean by this acute breathlessness, or how do we define this term as dyspnea? It can have several definitions, including it can be either uncomfortable sensation of breathing, difficult, labored or uncomfortable breathing, or it could be a sensation of feeling breathless or experiencing air hunger. If we move forward to a more defined structural definition that is given by American Thoracic Society, it defines dyspnea as subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. The experience derives from interactions among multiple physiological, psychological, social, and environmental factors and may induce secondary physiological and behavioral responses. But if you look at the prevalence, it is reported in almost 50% patients admitted to acute tertiary care hospitals, 25% patients in the ambulatory settings, and if you look at the age-wise prevalence, it is almost 9 to 13% in adults aged more than 18 years to 40 years, 15 to 18% in more than 40 years, and 25 to 27% in patients above 70 years or more. If we look at the simple pathophysiology, dyspnea results whenever there is imbalance between the perceived need to breathe and perceived ability to breathe. it results in two important conclusions, that is CO2 buildup and oxygen deprivation. These are the critical factors that result in dyspnea. And all the peripheral chemoreceptors or mechanoreceptors or brainstem respiratory center stimulates ultimately cerebral cortex, resulting in the perseverance of dyspnea. If we look at the etiological, it could be either 4 categories. I have divided it into 4 generative categories. It could be either cardiac, it could be either pulmonary, or cardiac plus pulmonary, or non-cardiac. So in cardiac causes, we have CCF, CAD, cardiomyopathy, vascular dysfunction, pericarditis, arrhythmias, whereas in pulmonary causes, we can have mainly COPD, asthma, restrictive lung disease, and pneumothorax. If we look at both the causes, cardiac plus pulmonary, it is COPD with pulmonary hypertension, or which we call cor-pulmonary, chronic pulmonary emboli, or non-cardiac causes could be metabolic conditions, pain in the chest wall, neurovascular disorders, otorhinolaryngal disorders, and others. There are many more to see. If we have look at the grading, we have 2 important gradings that we deal with in our daily clinical practice. One is the Medical Research Council or American Thoracic Society grading, which grades it into 0, 1, 2, 3, 4, categorized as mild, moderate, severe, and very severe. In grade 0, we have no trouble with breathing except for the strenuous exercise, trouble with shortness of breath when hurrying or on level or walking up a slight hill in grade 1. In moderate category, we have walks slower than people of same age. In severe category, patient stops for breath after walking 100 yards or after a few minutes on the level. And in very severe category, patient is too breathless to leave the house or breathes even when undressing or undressing. Another classification that we use commonly is the New York Heart Association classification, which grades it into 1, 2, 3, 4, with a grade 1 ranging from structural myocardial changes, grade 2 small decrease in exercise tolerance, grade 3 there is significant decrease in exercise tolerance, and in grade 4 we have symptoms of heart failure at rest even. So how do we approach clinically to these patients whenever a patient of dyspnea comes to us in our ED? We do go for an initial assessment, respiratory distress, and assess the clinical instability or hemodynamic stability. If patient is stable, then go for the history and the physical examination part. If the patient is unstable, then we need to stabilize first with supplement oxygen, pulse oximetry SpO2 or IV axis, and cardiac monitoring has to be attached. If the patient is able to protect his airway, then again move to the second part, that is examination part. Or if the patient is having trouble with breathing, then go for ventilation, intubation, and ventilation. If we look at the history, physical examination, it is essential to record the vital signs, extremities, systemic examination. We need to perform all the respiratory four system examination, and then we can plan for chest X-ray. Once we are done with the chest X-ray, we can rule out certain DDs we have in our mind. One could be either tension pneumothorax or hemothorax. Another could be interstitial pattern on chest X-ray. We can go for NT-proBNP if we suspect any heart failure or any cardiac lines. We can, if the chest X-ray is clear with chest pain, consider pulmonary embolism, acute coronary syndrome, and general equivalence. If we have bronchi with diminished low breath signs or infiltrate on chest X-ray, consider pneumonia or pleural effusion. Wheezing, clear chest X-ray, consider anaphylaxis or bronchospasm. Then, dealing with these clinical topics, we need to perform certain investigations further, and we need to manage it according to the symptoms, which we will see in subsequent slides. So this is an important part whenever we are assessing a patient of dyspnea or acute breathlessness. This should be meticulously recorded with onset, duration, pattern, progression, severity, and diurnal variation regarding the breathlessness, regarding the chief complaint, that is breathlessness, that the patient presents. If the patient has, and I asked about if the patient has acute causes, like onset is acute and sudden, or we can think of acute causes like in the respiratory cases, acute exacerbation of asthma, pneumothorax, pulmonary embolism, foreign body, or laryngeal edema. And in cardiac causes, we can have acute MI, CHF, pericardial tamponade, acute valvular insufficiency, aortic dissection, CHB. Ask about the onset and course, because if it is within hours, then we have certain causes to deal with, like asthma, left heart failure. Within days, if the onset is within days, then we can go for pneumonia, ARDS, left heart failure. And if the patient has within weeks, then we can think of pleural effusion, anemia, muscle weakness, tumors. Chronic pulmonary causes are already there we can have certain structural changes like airways, COPD, pleural, and parenchymal vascular, depending on the causes. But this is important because we have certain terms like orthopnea, platypnea, and tachypnea, along with other causes, because these are positional shortness of breath. So orthopnea means shortness of breath which occurs whenever the patient is lying flat, causing the person to have to sleep propped up in bed or sitting in a chair. We can think of CCF, left ventricular failure, COPD, bronchial asthma, massive pleural effusion, ascites or GERD. If it is platypnea, the causes could be either left atrial myxoma, massive pulmonary embolism, paralysis of intercostal muscles, or hepatopulmonary syndrome. If it is hypopnea, shortness of breath, that is lateral position, disease of one lung or bronchus, or we can think of CCF. Timing is acutely important because if it is nocturnal onset, think of CCF, COPD, bronchial asthma, sleep apnea. If it is postprandial dyspnea, then think of GERD, aspiration, or food allergy. Duration is also important because COPD asthma usually have a chronic variation. Pleural effusion can be within weeks. Small pulmonary embolism can be acute. Interstitial lung disease or malignancy could be subacute to chronic. Psychogenic causes and other cardiac diseases also should be ruled out. Then there are certain variations of dyspnea, which can be either intermittent episodes or exercise-induced dyspnea, or it can be either seasonal with bronchial asthma or aggravation of dyspnea during winter months, think of COPD. Then dyspnea associated with central chest pain, think of aortic dissection, pulmonary embolism, or acute coronary syndrome. Chest pain, sharp aggravated by a cough or deep breathing, think of pleural irritation. Dyspnea associated with fever, think of any infectious causes. If anxiety precedes, think of any panic attack or psychogenic dyspnea. Dyspnea associated with hemoptysis, think of TB, embolism, and malignancy. Physical examination is very important. Once we are done with the differential diagnosis or with the history part, then we should not miss out the physical examination. Physical examination of all the systemic organs should be carried out. It helps a clinician to assess the severity and diagnose the cause. Acute severe asthma cannot complete full sentences while talking. This is an important clue whenever we are dealing with patients of acute severe asthma in these winter seasons. Look for use of accessory muscles of respiration, paradoxical breathing, signs of pallor, cyanosis, clubbing, pedial edema, all important for examination point of view. Hemodynamic stability should be checked in ED department. Whether patient is able to maintain saturation or not, this is important and it should be assessed properly. Percussion, auscultation, JVP examination, all should be carried out and all should be recorded in your ICU chart or emergency chart. Once we are done with the history part, physical examination, all things have been done. Triaging is important in every setup because this helps you to categorize the patient and use your resources according to the place where you are working. Should be immediately evaluated and triaging should be done for signs of clinical instability such as suspected upper airway obstruction, it could be either stridor, tachypnea, gasping or breathing efforts, chest retractions, presence of hypotension, presence of hypoxemia, unilateral or absent breath sounds, altered consciousness. These are some of the checkpoints that I have given you to look for the triaging purpose. This could be some of the differential diagnosis based on your clinical examination and history. If you find Vij, you can think of COPD, emphysema, asthma, or allergic reaction. Pleuritic chest pain, think of pneumonia, pulmonary embolism, pneumothorax, COPD, asthma. Fever, think of pneumonia, bronchitis, TB, malignancy. Cough, think of pneumonia, asthma, COPD, or emphysema. Hemoptysis, pneumonia, TB, pulmonary embolism, malignancy. Edema, think of acute heart failure, pulmonary embolism. Pulmonary edema, think of acute and chronic heart failure, ESRD, and liver diseases, ARDS. Tachypnea, it could be either pulmonary embolism, acidosis, or anxiety. Once you are done with the differential diagnosis in your mind, you can plan your investigations accordingly. Go for lab testings further to move towards the final diagnosis. ECG should be obtained immediately in the ED. Chest radiograph should be done. CT of the chest if needed in cases of malignancy or severe breathlessness. Thoracic ultrasonography, this is important. Bedside ultrasonographies are available almost everywhere nowadays. You should perform it immediately. It will give you an important clue to rule out certain cardiac and lung diseases. Go for NT-proBNP, complete hemogram anemia, that is normal routine checkup. Then you have ABG analysis, which is also available in every ED. Cardiac biomarkers are important to rule out ACS and other causes. Pulmonary function testing, spirometry, if possible, go for it. So how do you manage? Once you are done with this, you have to manage the situation and cause. Recognize and manage the life-threatening disease, provide oxygen for hypoxic patients, manage upper airway or lower airway obstruction and lung collapse, relieve the bronchospasm immediately, provide ventilation support or intubation if needed, manage pulmonary edema, manage infection, tissue perfusion and metabolism, and provide pharmacological relief. Now, not possible to go in details, but in short, I will give you the clue of a specific treatment to certain diagnosis, certain clinical conditions that we manifest, that we see in the emergency department. In pneumothorax, go for aspiration, chest tube, fluoridesis, thoracoscopy, massive pulmonary embolism, high dose unfractionated heparin, dopamine or dobutamine with norepinephrine for pulmonary embolism related shock. Open surgical embolectomy, catheter thrombectomy can be done if you are working in a tertiary care center or a good center. Acute asthma exacerbation, go for inhaled anticholinergic drugs with beta-2 agonists in children, systemic corticosteroids. If there is acute exacerbation of COPD, try for beta-2 agonists, corticosteroids, antibiotics, oxygen, ventilator support. For pneumonia, a good grade IV antibiotics, oxygen therapy, IV fluids. For pulmonary edema, keep oxygen saturation greater than 90%. Intubation, preload reducers like NTG, diuretics, or afterload reducers like nitroprusside or ultrafiltration. If we are dealing with a case of metabolic acidosis, go for bicarbonate therapy. Usually it is recommended only when pH is less than 7.1 or 7.2, and treat the underlying cause. Psychogenic dyspnea, anxiolytics, paper bag technique, but may worsen the condition sometimes. Foreign body, Heimlich maneuver, supportive measures should be done, rhythmic epinephrine, or as temporary measure until bronchoscopy can be done, or perform bronchoscopy if it is available. Acute epiglottitis, intubation, steroids, antibiotics can be tried. So, to conclude with you, I give you good mnemonic comfort for summarizing the key therapeutic considerations. C stands for call for help. Keep yourself calm, your voice should be calm, and approach patiently to the patient. Observe closely, O for observe closely, and observe your findings carefully and assess dyspnea for the ways it can respond to you. M, look for the medications that can be tried based on the certain clinical and physical examination that you have done. Certain medicines should come up in your mind to calm the patient. That is, medications to be tried should be done immediately. F is for fanning of the face. Remove the crowd around the patient. Allow the patient to breathe properly. O for oxygen therapy is already done and you need to do it for saturations if low. R for reassure and use of relaxation techniques. Ask the patient and ask the attendant, consult the patient, consult the attendant if possible at every interval. T for timely intervention to reduce dyspnea and teamwork. Both can be a wonderful result. Work together, reassess, and do the repeat if needed. Thank you.
Thank you, Dr. Gagan. It was very simple and crisp way of presenting the approach to a dyspneic patient. Any question from PGs? If there is no question, then I will ask a question from PGs on behalf of Dr. Gagan. Tell me what can be the cause of if a 15-year boy come to the emergency with dyspnea and there is no finding in the chest and the heart. The chest is bilaterally equal air entry, heart is there is no murmur. What can be the cause and what will you do? A patient is dyspneic, it is around 25 respiratory, 25 to 30. And it is quite subacute type of presentation. Anyone? Raise your hand and tell me. Very good. So in that thing we have to do ABG and that can cleanse the report. Thank you.
Thank you so much.
No, I will, excellent talk, Gagan Gunjan, as usual. And usually young persons panic attacks, maybe that one of the diagnosis. Apart from that, you have done that diabetic ketoacidosis should be, yeah. Thank you, Dr. Gagan. Oh, yeah.
I just want to one thing, particularly in pulmonary embolism, we are seeing the patient of acute dyspnea and casualty. This is for students to learn the things. Thing is the how we can rule out pulmonary embolism and research limited setting in acute care. First thing, you do one ABG, calculate arterial and alveolar gradient, A minus A, capital A minus A, formula was there. If it is falling within normal range, in like pulmonary embolism is almost ruled out. Other than if you say D dimer, it will take times to come. Actually, in particularly this part of in Devghar and all, protein C deficiency, antithrombin present subacute chronic pulmonary thrombolysis is quite common. So whenever you are seeing, calculate that thing and you have to rule out pulmonary embolism in a quite confident way. Other thing what like pneumothorax, pneumonia, other cardiac disease can be ruled out by simply advising ECG, X-ray, ABG. That's all.
Thank you for your valuable inputs. Pulmonary embolism is quite common, and we often see at RIMS Ranchi. We have seen many cases and we deal with it. Patient is in acute chest pain, and often the initial investigations are negative, but we have to send a D-dimer for our screening purpose, and rest, as you said, we go for ABG and other things also. Thank you so much.
She is Dr. Archana Malik from AIMS Devgar. So please give her the big hands. She has come for the second time, I think, no? Second time. Once she has been invited in the Department of Respiratory Medicine. Okay, Gagan, thank you very much.
Thank you, sir. Thank you all.
Thanks to us.
Yeah, glad.
Thank you, ma'am. Thank you.
And our next speaker is none other than Dr. Sanjay Kumar. He is a respiratory physician and is a well-known figure in Bihar and beyond Bihar. So in the pulmonary forum, Dr. Sanjay Kumar has been the postgraduate PG in TB and chest disease in AK and Sinha Institute. And he is the director chest clinic at Patna, associate professor and HOD medicine, Buddha Institute of Dental Sciences, Patna, and a visiting physician in Heart Hospital, Patna, and Jivak Hospital, Patna. And the topic is very important, that is ABPA, and usually you know that such patients we diagnose whether it is a case of asthma or something, and how to pick up such ABPA cases, how to diagnose and how to deal. Over to Dr. Sanjay Kumar.
Thank you, sir, for kind introduction. I will be talking about allergic bronchopulmonary aspergillosis. It is a very common and prevalent disease, but less talked disease. I would like to say the basics of how to diagnose the ABPA and how to manage the ABPA. There is nothing to disclose. Well, ABPA, as its name suggests, this is basically due to the fungus, the aspergillosis. That is the ubiquitous fungus, and as per the immune status and pre-existing disease of the patient, it may present in different forms, right from the aspergilloma to angioinvasive aspergillosis. If there is a lung cavity, we may find aspergilloma, and if there is immune suppression or neutropenia, we may be getting angioinvasive aspergillosis. ABPA is one of the presentation which is more common in the patients of the bronchial asthma and cystic fibrosis. So basically, ABPA is an inflammatory lung disease, and it is being caused due to the hypersensitive reaction which occurs in response to the colonization of the airway due to the Aspergillus fumigatus. A similar type of syndrome may be found due to the other Aspergillus species infections, and that we call it as ABPM, that is the mycotic diseases. Very pioneer work has been done at the PGI Chandigarh by Ritesh Agrawal, and in his paper only published a few months back, he has said that the prevalence of ABPA in India is almost double from the other countries. So it is a very much prevalent disease in India, and as per a rough estimate, they have said that about 1.4 million ABPA cases are in India. So the problem is very big, but we don't take it very seriously. As I have told that it is being caused by the Aspergillus species. There are almost 100 Aspergillus species in the nature, but it is the fumigatus species that is the most that is causing the Aspergillus bronchopulmonary allergy. It affects people who are asthmatic or have cystic fibrosis and at the same time are allergic to aspergillosis. But all the patients of asthma and cystic fibrosis do not have the ABPA. So there are host factors. Basically, there are some genetic associations of DLA genes which predisposes the persons to have the ABPA. And there are certain HLA-DQ gene which provides protection also. So host factor and environmental factors both are very important so far so the ABPA is concerned. As it is very much ubiquitous, so person inhale the fungal spores, but if the immunity is proper, due to the body's immunity, it is being cleared out. But if the immunity is poor, it colonizes and infection occurs. Once it colonizes, it gives the disease. What happens? It is the spores, which are very small, 2.5 to 3.5 mm, are inhaled into the lower airway and alveoli. And once it colonizes, it grows there in the hypha, and then it attaches to the cells, and there it causes the allergic manifestations. Coming to the clinical presentations, there is no such a specific clinical presentation. It usually the presentation of the basic disease, that is the disease that is of the asthma or the cystic fibrosis. But there are recurrent episodes of wheezing or recurrent exacerbations of the asthma that may give you suspicion that the patient may have some ABPA type symptoms, disease. There are certain non-specific clinical presentations like anorexia, fatigue, generalized ache, sometimes low-grade fever. These all, if in the predisposed persons is present, you must think of ABPA and you must work up there. Clinical examination again is just like the presenting disease, that you may find the wheezing as in asthma, or if there is cystic fibrosis, you may find some Krebs. Tachypnea may present in cases of asthma exacerbation or due to sometimes the secondary lung infections. So these are very non-specific physical findings. So how to diagnose? It is basically based on the clinical manifestation, patient history, and certain tests. The three important tests is skin prick test, blood abnormalities, and measurement of the immunological markers in the blood, and imaging, X-ray and HRCT. Coming to the Aspergillus skin test, it is the most commonly used skin test so far so the ABPA is concerned, but mind it, just like Montus test, it is not diagnostic. It just diagnoses the sensitization of the patient to the Aspergillus fumigatus. It is basically a cutaneous hypersensitivity reaction, that is type 1 hypersensitivity reaction, and it represents the presence of A fumigatus specific IgE antibodies in the patient. Intradermal skin test may also be done, and it is rather more sensitive than the skin prick test for the diagnosis of the Aspergillus sensitization. So it is basically a test of the sensitization, not a foolproof test of the ABPA. Coming to the blood abnormalities, we see two things. One is the immunological markers, and other is the eosinophil count. We measure total serum IgE, which is markedly elevated, and we also measure IgE specific to Aspergillus fumigatus, which is elevated. Third thing is we have to measure to see for the presence of serum precipitin or raised specific serum IgG to Aspergillus fumigatus. So these are the immunological markers that we have to see in the blood. At the same time, we will have to count the blood eosinophils. That is the absolute, we have to measure the absolute count of the eosinophils, but it may not be raised all the time, as the patient of the asthma is already taking inhaled corticosteroid or sometime oral corticosteroid. Imaging is again very important, and as first imaging technique is that we use is the X-ray. But X-ray has only 50% sensitivity for the diagnosis of ABPA. You may not get any changes in the chest X-ray, but still the patient may have the ABPA. So do the X-ray. There may be the findings, but sometimes there may not be findings. You can find the parenchymal infiltrates which are fleeting in nature, And sometimes you may find the bronchiectatic changes. There are other specific findings also that can lead to the diagnosis, that is finger in globe opacity. It is basically the mucoid impaction in the dilated bronchi. Another is tram line shadow. It basically suggests the parallel line shadow extending from the hilum in the bronchial distribution, and it is basically reflect the longitudinal view of inflamed and edematous bronchi. Third is the toothpaste shadow. It is again represent the mucoid impaction of the bronchi. And last is the ring shadow, reflecting dilated bronchi with inflamed bronchial walls. You may find it, you may not find it in the X-ray. So all the changes in the chest X-ray can either be transient, that I have already told, it is fleeting, or sometime it may be permanent. The transient changes are basically the changes due to the mucoid infection, that is the toothpaste and glove finger shadow, while the ring shadow and the parallel line shadow, or sometimes in the very advanced case the pulmonary fibrosis feature shadows, that is typical in the upper lobes, are the permanent changes that you may find in the X-ray. So next, you can see this X-ray. In this X-ray, you can see the fleeting change, the changes in the right lower lobe, which is not which disappeared after some treatment. Again, this chest X-ray, if you see, you can see the shadow of the nodular opacity in the right middle lobe. And this is the mucus impaction looking like glove finger shadow. That is the arrowed shadow. This chest X-ray, again you can see the ring shadows representing the bronchiectatic airway, and the tram lines, that is a short arrow. If you can appreciate, it is seen in the longitudinally. So the investigation of choice is HRCT. It detects a lot of things that you may not be getting in the chest X-ray. It can detect bronchiectasis, not only its bronchiectasis detection, but it can locate the distribution also of the bronchiectasis. Either it is central or peripheral. You can detect the centrilobar nodules, tree in bud appearance. All these can be found in the chest X-ray. But again, there is a catch. There are features of the ABPA. Serologically, you can find the immunological marker, but still you may not be finding any shadow in the CT scan also. And that type of ABPA is called ABPA-S. That is the ABPA only on the basis of the serologic. Again, there is a category that is called ABPA-CB. That is ABPA with central bronchiectasis. In this CT scan, you can jolly well see the mucus-filled dilated bronchi and the central bronchiectasis. That is very much evident in this X-ray. The mucus-filled bronchi is the white shadow that is on the right lung. This X-ray, this CT is also very nice. If you see on the left panel, you can see the central bronchiectasis, and on the mucus-filled spaces, and on the right there is tree in bud appearance. In the lower two films, that is very important, you can see it is called HAM. That is high attenuated mucus. In the lung window, you can see the white shadow, and in the another window, you can also see the white shadow. How you can say that it is HAM? It is nothing else, because its attenuation is more than the attenuation of the paraspinal muscles. So it is HAM. This CT scan, you can see the thick-walled bronchi. The arrows show the thick-walled bronchi, and there are mucus-filled shadows also. This is again the mucus-filled shadow, white shadow. So CT scan is very important so far, so the diagnosis is concerned. There are other adjuvant investigations which can be done, but it is not being done all the time. Bronchoscopy, sometime it is being done. You can find the mucus impaction in that in bronchoscopy, and if you do the bronchial brushing, you may reveal mucus that contains the aggregates of eosinophil and the fungal hypha. and sometimes charcoal-laden crystals. These findings of hypa filled with mucus plug is very much pathognomic of ABPA, but it is not always been done. A sputum culture for Aspergillus fumigatus, it is again being done, but it is not diagnostic. If it reveals an organism, it may help in the treatment by susceptibility test. Another two tests that I would like to mention here is galactomannan detection and basophil activation test. Galactomannan is basically a polysaccharide that is present in the cell wall of the Aspergillus. It is being released when the Aspergillus grows, but it has very poor sensitivity, so it is not always been recommended, and rather it gives a clue to the invasive variety of Aspergillus fumigatus infection rather than ABPA. Basophil activation test is again very good test, but the limitation is that it is being done by the flow cytometry, and it is not being done at all the places, and its utility is very limited. So all these tests can help, but the important is the blood test and the imaging. On the basis of the clinical and the investigative findings, there are diagnostic criteria. The first diagnostic criteria was put forth by Rosen and Peterson in 1977. They have put the primary criteria and the secondary criteria, but this criteria was silent about how many the criteria should be there to diagnose a case. So these criteria were further revised by ISHM, and they have put the criteria as predisposing conditions, that is asthma of cystic fibrosis, with obligatory criteria, the two obligatory criteria, and any of the two in the three criteria. The criteria has again been modified in 2021 by Ritesh Agrawal group in the PGI, and it is the important criteria for so far so India is concerned, that all should be present, that is Aspergillus fumigatus specific IgE more than 35 kUA, and serum total IgE more than 500 unit per ml, and two of the three, that is A fumigatus specific IgE more than 27, bronchiectasis on CT thorax, or peripheral blood eosinophilia count more than 500. There are another criteria which is being used in other parts of the world. So on the basis of that, they have put the algorithm that in the patients having the risk factor and having a high specific IgE to A fumigatus, we should measure the total IgE, because the total IgE is important so far so monitoring of the disease is concerned. If it is less than 500, it is a case of Aspergillus sensitized asthma, and manage it as asthma and repeat the total IgE every 2 to 4 years. If the total IgE more than 500 international unit, and there is Aspergillus specific, measure Aspergillus specific IgG, eosinophil count, and CT chest. Two of the following if present, you manage it as ABPA. Treatment goals are controlling the symptoms, preventing the exacerbations, and preserving the normal function of the lung. The three basic drugs that we use is the anti-inflammatory drug, antifungal drug, and anti-IgE therapy. The corticosteroid of choice is glucocorticosteroid. It is being given in a dose of 0.5 milligram per kg per day for, may I have one more minute?
Yes, sir, continue.
4 weeks, then taper to 0.25 milligram for 4 weeks, then 0.125 milligram per kg per day for 4 weeks, and then taper accordingly. We may add the oral azoles, and the two azoles that is being given is the either itraconazole or voriconazole. There are certain reports regarding the nebulized amphotericin B, liposomal amphotericin B, and amphotericin B lipid complex, but randomized control trials are missing. It is still in the investigative stage. In the IgE group, we may give the omalizumab because it is basically the difficult to treat asthma cases, and we may give omalizumab as an adjuvant. Follow-up is very important. Follow-up is being done by clinical symptoms, that is a cough, dyspnea, chest radiograph, and total IgE. And the satisfactory response to the therapy is suggested when there is clinical and radiological improvement along with at least 25% decline in IgE level. So monitor IgE frequently to establish the new baseline, because it may not come to near normal. So you will have to define the new baseline for that patient and monitor for the treatment-related adverse effect and the drug reactions. Once the clinical or radiological worsening along with more than 50% increase in IgE level, we suggest, it is being suggested that ABPA exacerbations and need further treatment. So it is very important to diagnose early so that the lung function is preserved or further lung damage is not being done.
Hello.
Thank you.
Thank you, sir. It was a nice presentation. Any question? Anyone we can take if there is one query? Otherwise, we
Due
move
to
on to
time
the
limitation, we can take only one question or one comment.
So ABPA is a, I think it's, as sir has rightly addressed, that it is a underdiagnosed condition. In a patient of asthma, when the patient is not recovering, then we definitely rule out, I think, we definitely rule out this condition by doing HRCT and other tests. So thank you, sir. Thank you for a brilliant presentation.
Thank you.
Thank you so much for such a wonderful talk. I would like to request our chairperson to please introduce our next speaker.
Our next speaker is Dr. Rajesh Kumar. He is HOD Medicine, AIMS Patna, very pious place. He is coming from Devghar. Pious place, Devghar. And he is ex-faculty, AIMS Bhubaneswar, Jipmer, ex-alumni of AIMS Delhi. And he has published more than 25 international publications, has more than 16 years of experience in rheumatology, and presented papers in many conferences, and the many awards has been given to him. So over to Dr. Rajesh Kumar, and he's going to give us approach to a very important topic, that is autoimmune disease. And as you know, the incidence of this are increasing, and there are more and more diagnoses is being done, because it's usually an underdiagnosed disease, and we have to suspect and we have to diagnose these cases of autoimmune disease, and treatment also is specific. Over to Dr. Rajesh Kumar for your talk.
Thank you, sir, for kind words, and greetings from AIMS Devghar and to whole of such a beautiful organization. Thank you for inviting me, sir. Today I will be talking to approach to an autoimmune diseases. As sir told, that the prevalence and incidences has been increasing since nowadays. So no conflicts of interest, and the images have been used after the consent, and the clinical photos have been used with masking after their consent for use in academic purpose. The layout of my talk would be what are the autoimmune diseases, the identification of them, and how to approach them with the case-based studies. So what are the diseases? What autoimmune diseases are basically a pathological state caused by an abnormal adaptive immune responses as against autoinflammatory disorders, which are because of innate immune responses. So that's a very important point to be learned, and these autoinflammatory disorders are mostly occur in children, and they are monogenic disorders as against autoimmune disorders which are generally found in children, and we know it is rheumatoid arthritis, Sjogren's, and inflammatory myopathies. So how to approach? The history taking point is the most important, and 60%, 80% is an important step one recognition of approach. Second, step two is physical examination, and antibodies, which we fancy, and imaging is 5 to 11% only. After this, the step four is application of a classification criteria, but it is more of a research purpose rather than diagnosis of patient in your OPDs. And then you have to start an apt treatment accordingly. So if we broadly classify what are the things which we deal with, it is the arthritis, that is the joints, if there is a systemic involvement or not, and the vascular component. So these are the three more important components in an autoimmune disease. Now let us start with a case one. This is a 42-year-old who came to the OPD, my OPD, with the pain and swelling in joints of hands with a morning stiffness of 2 years, and she has been using NSAIDs with mild relief and no other systemic complaints. So now how to approach this patient? Okay, fine. So first of all, we have to say whether it is an arthritis or arthralgia, whether it is pain or pain plus swelling, whether it is inflammatory or non-inflammatory. Inflammatory means there is an early morning stiffness of 30 minutes. And what are the types of joints which are involved? Very important. Is there any extra articular features? And the most important, whether this pain is coming from the articular or it is the non-articular that is coming from bursa or any muscles. So that's a very important. Let us peep into the joints before I proceed further. There is an axial joint, the root joints, which are the shoulder and the girdle joints, and the peripheral joints are the large joints and the small joints of the hands. And the clinical examination, typically we have go with the gait, arms and legs and spine. So if you see the different patterns, we have an acute versus the chronic, the number of joints involvement, whether they are additive, migratory, intermittent, or peripheral, or axial, symmetric versus asymmetrical. Now if you see an acute versus chronic, acute is known as a duration of 6 weeks, and the most important ones in inflammatory are either they are infective like tuberculosis in our India, or it is the crystal-induced arthropathies, which is CIAs. The duration, the chronic, the most important ones are rheumatoid arthritis, the SLE, and the spondyloarthropathies. What is the number of joints involved? Whether it is monoarticular, oligoarticular 2 to 4, or more than poly 5 or more. So if it is monoarticular, always think of infective and CIA. In oligoarticular, psoriasis and spondyloarthropathies, and in inflammatory part, the polyarticular is rheumatoid and SLE. The different patterns, peripheral, I just wanted to one thing, is that if there is a young male coming to an OPD and is presenting with a pain in the vertebral column or the low back pain, always have a think of spondyloarthropathy. So spondyloarthropathy can have an axial manifestation plus or minus peripheral manifestation. There are certain patients who can present with the peripheral. So if you see the RA, the DIP is spared. In psoriasis, DIP is involved. Same is in with the lower joint. First metatarsophalangeal joint, gouty, think of gout. And if it is the PIP joint, so if the DIP is psoriasis. If it is an ankle joint, think of spondyloarthropathy, think of sarcoidosis. So back to this clinical case, this was a patient of inflammatory polyarthritis. This patient had a presentation of an interstitial lung disease, and on X-ray he had an erosive changes, and the RA factor and ACPA was positive. So this was a patient of seropositive rheumatoid arthritis. Systemic involvement, we have to look with the skin and the mucosa and the subcutaneous. GI is very important for reactive arthritis. Eyes are very important clue for the diagnosis of connective tissue diseases. Renal diseases, as we discussed in lupus, very important. Vasculitis is another one, and there is a whole paradigm in lung diseases that is known as interstitial lung diseases. So this is the case 2. This is a lady who presented, young lady presented with the skin lesions and inflammatory polyarthritis and recurrent oral ulcers with a fever since 3 months. And how did he approach this patient? Again, she had an inflammatory polyarthritis. She had some cutaneous features which are typical of SLE, and she had a recurrent oral ulcers. And when we did an antibodies, ANA and NA profile was suggestive of lupus. So ANA IFA pattern, homogeneous 1:80 titers is suggestive. Similarly, we again now go with the ANA profile, and we have a lot of antibodies. So don't get fancied about the antibodies and ANA. It is the clinical and only clinical which clinches the diagnosis of SLE. They are all supportive. After that, we rule out, we apply over the classification criteria. Again, I am then telling classification criteria is only research for purpose. It can add to your diagnosis, but should not be included. This is another inflammatory back pain low patient of our MBBS graduate presented with a 20-year low back pain with 6 months of early morning stiffness more than 1 hour. And he had an asymmetrical oligoarthritis, mainly the large joints, and he had an Achilles tendonitis. So he has a tendonitis, he has a asymmetrical oligoarthritis with an inflammatory low back pain. This complies to the diagnosis of a spondyloarthropathy, which encompasses a lot of angst-spawned reactive psoriasis, juvenile and undifferentiated. So first ascertain whether it is inflammatory low back pain or not. So patient should be young, insidious onset. Mostly the pain is in the second half of the night, and when he gets up in the morning, he has a lot of stiffness which lasts more than 30 minutes. So that's a very important thing. And always step one is whether there is an axial or not, peripheral or not, or both of them are present. Then identify the red flag signs which are indicative of compressive causes, claudication like lumbar canal stenosis, or infective like tuberculosis. Look for extra-articular manifestation like dactylitis in psoriasis, episcleritis and scleritis in eyes, psoriasis skin manifestation, Achilles tendonitis, Crohn's disease, which may go into reactive arthritis or interstitial lung disease. So clinical history and clinical examination of this patient, there was an inflammatory low back pain, there was an axial and peripheral manifestation, and there was an extra-articular manifestation in the form of Achilles tendonitis. And when we did a CT scan, there was erosive changes in the sacroiliac joint with an HLA-B27 positive, and this clinches the diagnosis of spondyloarthropathy. This is a 34-year-old pain, a lady, a male presented with the pain and swelling in the right knee, and he had a preceding UTI, documented UTI. That's a very important class, important for diagnosis of reactive, 3 weeks back, and he had some lesions in the penis, and that is sarcinate balanitis and keratoderma balanergicum, and this is what? Reactive arthritis. This is a 23-year-old having skin lesions with the nail changes, inflammatory arthritis, think of psoriasis, and dactylitis. DIP is very important thing. DIP involvement is there. So this is a psoriatic arthropathy. Case 6, this is a very 42-year-old lady, presented with me with some pneumonia-like features. When I started seeing her teeth, there was total tooth decay, and she had a hospitalization history of paralysis of whole body, which was subsequently with IV medication, but perhaps with potassium, and it got corrected. So Sjogren's syndrome, Sicca symptoms is there, always, not always. Nowadays, 2/3 of cases we are seeing extraglandular manifestation in the form of polyneuropathy, in the form of distal RTA, distal renal tubular acidosis. So always think of that when a patient comes to you. Never think only Sicca symptoms may be present for clinching a diagnosis of Sjogren's. This is a 42-year-old presented with Raynaud's phenomenon. We have a skin tightening and limited opening with a ILD, interstitial lung diseases, and digital pits. This is a patient of systemic sclerosis. So tightening of skin with difficulty, dysphagia, with history of interstitial lung disease, think of systemic sclerosis. How would you approach a patient of proximal muscle weakness? Very important. We always think of some muscular disorders, muscular dystrophy, like this. When a patient presents with a bilateral symmetrical proximal muscle weakness, think of cutaneous features. Are there any cutaneous skin lesions like Gottrin's papules in the knuckles, or heliotrope, some lesions around your eyes, some lesions around your back? And if there are elevated muscles and coupled with your EMG findings, it may clinch the diagnosis of inflammatory pyomyopathy. So we have 5 groups: dermatopolymyositis, necrotizing myopathies, and anti-Jo1 syndrome. So proximal muscle weakness, if there are cutaneous features, ILD may be present. Think of always dermatomyositis, and if the cutaneous features are not present, rule out other causes by antibodies, which are now a very good tool for diagnosis, or like anti-MI2, anti-Jo1, anti-SRNP. If they are negative, think of polymyositis. Anti-synthetase syndrome is not so uncommon as we used to think of. So there are patients presenting with your inflammatory myositis, arthritis, interstitial lung disease, anti-Jo1 positivity, and you have a mechanic hands. The hands look like mechanic. So there are lesions in the hand which are found. So these are mechanic, which are anti-synthetase syndrome. MCTD, we are very bogged up with this. What is this term? Actually, MCTD is nothing. It's a high urine iron P titers, which can be also found in SLE. So if in SLE we do an antibody testing, it finds and urine iron P titers, it is not MCTD. MCTD is high urine P titers with 3 of the following. We have a Raynaud's, we have a swollen hands, arthritis, myositis, and interstitial lung diseases. Vascular involvements are very, very important. This is a male who presented with a skin rash with upper and respiratory tract infection along with microscopic hematuria. Always think of vasculitis. So cutaneous manifestation, any form of rash, peripheral gangrene, liporeticularis, plus or minus arthritis, and any systemic involvement, think of vasculitis. And we go with a small, if you think of small vessel vasculitis, go with ANCA. We have a PR3 positive or a MPO positive, that is C ANCA and P ANCA respectively. We have GPA is C ANCA and GPA, that is granulomatous polyangiitis. This is a 28-year male with an acute onset of knee joint pain, and the X-ray, when we did an X-ray, it revealed a bilateral hilar adenopathy. This turned to be a patient of sarcoid, and this is a Lofgren syndrome. So what are the things to be look in a patient who comes with an arthritis and has a fever? Always think of SLE, adult onset Still's disease, vasculitis, and if there is a children, autoinflammatory Still disorders like familial Mediterranean fever, CAPS, etc. The mimics are always rule out any infective causes. Of course, that's the paradigm. Rule out any tuberculosis, rule out any brucellosis, etc. So how do you approach a patient of AIRDs, that is anti-rheumatic disease in a nutshell? If a young male coming with that, with an asymmetrical oligoarthritis, suspect spondyloarthropathy. If a young female comes to you, always suspect SLE. Don't go with the RA. RA is found in 35 to 45 years of age, may be found in young. If a female of 35, 45, 55, suspect RA. Then you don't suspect SLE in the first point. And if this female presents with your Zika symptoms, suspect this Sjogren's. If a female of 20 to 40 years present with skin tightening, Raynaud's, ILD features, suspect systemic sclerosis or limited systemic sclerosis. If a patient presents with a proximal muscle weakness with cutaneous features, think of dermatomyositis. If cutaneous features are not present, think of polymyositis. There are dermatomyositis patients also presents without cutaneous features as well. So that you have also to think. A patient of female having 30 to 50 years of age with Raynaud's phenomenon, myositis, ILD, with high RNP titers, think of mixed connective tissue disease. And a female or a male, young male coming to you with a skin rash with systemic involvement, and some renal also involvement, think of small vessel to medium vessel disease. So that suspects, and you can proceed further for your workup. So proper clinical history is very, very important. There is nothing like not taking a proper clinical history. Note the systemic involvement, very important. Always systemic involvement, lungs involvement, renal involvement, even the CNS. Now we see a lot of patients of neuropsychiatric seizures and now presenting with SLE for the first time. Pneumothorax, I have seen patients presenting with the pneumothorax coming with the connective tissue disease. So never just omit any symptoms. Whenever a young patient is coming with a multisystemic or systemic involvement, always think of nothing like meticulous clinical examination. Relevant lab, we get fancied about ANAs and ANA antibodies and all those stuffs, which are a lot of research. In a normal OPDs, even a good clinical and meticulous examination coupled with some of the relevant investigations clinches your diagnosis. Establish the diagnosis, apply the clinical criteria, and there is a known as disease activity scoring. So when you calculate the disease activity scoring, there are a lot of apps in it. Initiate updated treatment and follow up for the key. The biggest assets in the world is in your mindset. अगर आपका mindset ही बोलता है इन्हें ही कराना है, इन्हें profile से ही होगा, तो नहीं होगा. And Googling, even though doctors, we see a lot of residents Googling in the area, so we have to stop Googling. We have to know about the disease. We have to study. Thank you. Enjoy your Sundays. Thank you, sir.
Thank you, Dr. Rajesh. It was wonderful presentation. I think it will be most benefited to the PGs because it is still remain dilemma whom to treat, how to diagnose, and what investigations we prescribe to a patient once they reach our OPDs. Any question from the audience?
male is lupus is a? Yeah, definitely, yeah. So what we have seen in our study, as you told rightly, I did a study in AIIMS Bhubaneswar, and I was in the AIIMS Delhi also, and I've been there. Initially, we used to find very less number of patients of male SLE, but nowadays we are getting male lupus, but it's in sizable number. ऐसा नहीं है कि हम नहीं देखते हैं, but these do present with lot of systemic involvement. So lupus nephritis, and I have found lot of patients with interstitial lung disease. So what they differ is that they have lots of systemic involvement as compared to your young lupus, young male. Similarly applies with the old lady with the lupus. Generally lupus comes in young age. Old lady, systemic involvement more than your other features.
Hello. Thanks to our chairpersons and our speaker. With this, we are concluding this session. Thank you so much for such a wonderful talk, sir.
Thank you.
And let's move forward. And we have a workshop by Dr. Ajay Sinha and Dr. Kishore Junjunwala. I request our previous speaker to please proceed for a felicitation and for a group picture photograph. This workshop is going on to be on CPR and ALS, that is Advanced Life Support, by Dr. Ajay Sinha. Workshop will be conducted by Dr. Ajay Sinha and Dr. Kishore Junjunwala. All pharma representatives are requested to join this workshop.
और मशीन आपको प्रॉम्प्ट करती है, वो कहेगी एनालाइज द हार्ट रेट, क्लियर अवे चार्जिंग, क्लियर अवे फ्रॉम द पेशेंट. जैसे ही आपको कहेगी क्लियर अवे, मरीज से दूर हो जाइए, फिर उसके पाए कहेगी कि शॉक एडवाइजेबल, इसको लगेगा शॉक देना है तो कहेगी शॉक एडवाइजेबल. जब शॉक कहेगा दीजिए, उस समय ग्रीन येलो बटन आएगा, ऑरेंज बटन, उस ऑरेंज बटन को आप प्रेस करेंगे तो शॉक डिलीवर्ड हो जाएगा। जैसे ही शॉक डिलीवर्ड हो गया, एक बार शॉक डिलीवर्ड हुआ, तुरंत आपको क्या करना है, फिर से चेस्ट कंप्रेशन। क्या करना है, फिर से वही साइकिल 30:2 की साइकिल आपको चलाती रहनी है। और ऐसा हर 2 मिनट पे फिर देखना है कि मरीज जग गया हो तो छोड़ देना है, पल्स आ गया हो तो छोड़ देना है, या फिर आपके पास हेल्प आ गया हो, जो एडवांस आ गए हो, एम्बुलेंस आ गया हो, या फिर आप थक गए हो। सो दीज आर द ऑप्शन जो पूछ रहे थे कि कितने देर सीपीआर करना है। आप सोच लें, इज नॉट अ वनडे मैच कि इंडिया को अगला वर्ल्ड कप मिल जाएगा फिर खेलने का। यहाँ पे जो जान गई सो गई, वो दोबारा जीवित नहीं होगा, और आपका प्रयास उसके जीवन को बचा सकता है। और इतना एश्योर करता हूँ कि इतनी बातों का आप ध्यान रखेंगे, कैसे कंप्रेशन करना है, तो आप निश्चित तौर पे कोई ना कोई जिंदगी बचा रहे होंगे। अब कैसे चेस्ट कंप्रेशन के वक्त पोजीशन क्या होगा, वो थोड़ा सा एक हम लोग डेमोन्स्ट्रेशन दे दें। रखें इसको नीचे, इसको ले आए ना सर आगे।
इसको लगाया गया राइट कॉलर बोन के नीचे, राइट कॉलर बोन के नीचे, और ये कहाँ है, एपेक्स पर,
निपल पे, लेफ्ट बाईं तरफ के निपल पे
चिपक गया। बाकी काम मशीन ने करना है, कोई आपको कुछ मैनिपुलेट नहीं करना है। इट्स नॉट ए कॉम्प्लेक्स कंप्यूटर, ऐसी कोई चीज नहीं, अपने आप ही बताएगा, गाइड करेगा मशीन। मशीन विल स्पीक कि क्या करना है, कब शॉक करना है, मशीन बताएगा। यदि रिदम आ गया, हार्ट का चाल आ गया, तो फिर दोबारा नहीं बताएगा। हार्ट का आपका चाल बता आ गया तो दोबारा बताएगा नहीं, ठीक है। और लेकिन मसाज करने का जो प्रक्रिया है उसको कभी बंद नहीं करना है। शॉक करने के बाद तुरंत वो करते रहना है, आपको करते ही रहना है,
सीपीआर।
ठीक है। तो बेसिकली यही है।
Paramedics are requested to come
उसको
to the
सटा
front
दो।
row. They can sit here.
प्रेशर जाएगा मरीज के ऊपर बिल्कुल 90 डिग्री पे, 90 डिग्री पे सीधा रहना है। ताकत लगेगी आपकी कंधे से, जो कुहनी है वो सीधी रहेगी, ताकत लगेगी बिल्कुल कंधे से। और आपकी गिनती होगी, मैं दिखला रहा हूँ, इन दो निपल लाइन के बीच में हाथ का पोजीशन ऐसे, कंधे से ताकत, और बिल्कुल जाएगा ये ताकत ऐसे। 1 2 3 4 5 6 7 8 9 10। और जब भी दबाए हैं तो वहां हमने छोड़ा है, दबाया है, छोड़ा है, क्योंकि दबाएंगे तो ब्लड जाएगा ब्रेन में, छोड़ेंगे तो ब्लड वापस आएगा हार्ट में। दिस इज द रूल। 1 2 3 4 5 6 7 8। आप देखिए ताकत बिल्कुल कंधे से लग रही है, और ये दोनों हाथ स्थिर है, और मैं बिल्कुल इसके ऊपर 90 डिग्री पे हूं ताकि पूरी ताकत ट्रांसमिट हो। 1 2 3 4 5 6 7 8 9 10। सो दिस इज द वे। सारे लोग जब प्रैक्टिस करेंगे, जब आपने वीडियो में देखा एक छोटे बच्चे 15 साल के बच्चे कर सकते हैं, तो हम सब लोग कर सकते हैं। जी सर। हाँ नहीं बिल्कुल। और हमने एक बात और है, जब भी आप कार्डियक अरेस्ट कंडीशन को कह रहे हैं तो गद्दे पे ना करें, है ना। कोशिश करें कि जो सरफेस हो वो हार्ड हो, नहीं तो आपको ताकत नहीं लगेगी। हार्ड सरफेस पे हो, जैसा सोफा जैसा नहीं हो कि सोफा पे, एक वीडियो वायरल हो रहा था, एक किसी ने सोफे पे बैठे हुए थे नेताजी और उनको कार्डियक मसाज शुरू कर दिया था। तो उस तरह की जोकराई नहीं करनी है, हार्ड सरफेस पे रखना है, सीरियसली परफॉर्म करना है, और डेफिनेटली बाय डूइंग यू आर गोइंग टू सेव द लाइफ। तो अब जो है हम लोगों ने जो जितनी बातें की उसमें कितनी बातें याद रहती हैं, और असल में पढ़ाना था ACLS, हम आ गए हैं BLS पे। एनीवे, मैं अब 3 लोगों को वॉलंटियर करके बुलाता हूं, जितनी बातें अभी तक कही हैं, देखते हैं कितनी बातें याद हैं। कौन लोग सेल्फ वॉलंटियर होना चाहते हैं? यस प्लीज कम। थैंक यू सो मच। अभिराज, हाँ, एंड आप भी आ जाइए। यस प्लीज कम। बहुत बढ़िया अभिराज, आपका तो नाम हमने देख लिया। कौन सा ईयर है? 2nd ईयर है। आपका नाम?
ब्यूटी कुमारी। क्या करती हैं आप? ANM है सर।
ANM है, बहुत बढ़िया। आप?
पूजा कुमारी।
आप क्या कर रही हैं?
ANM
है। एक फार्मा के भी लोग थे, फार्मास्यूटिकल साइड से, कौन है? कोई एक जन आ जाइए प्लीज, आइए। यस कम। ये हुआ सेल्फ वॉलंटियर। सर जी आप अभी अपने बाहरी काउंटर पे थे, है ना, और आप करेंगे हम सब लोग देखेंगे, है ना। आपका शुभ नाम? समीर। समीर जी आप थे अभी बाहर काउंटर पे ही थे, काउंटर नंबर 10 के आसपास थे आप, और आपने देखा कि आपका एक कलीग जो है बात करते करते गिर गया है। ये आपके कलीग है, अभी हम लोग कोई भी नहीं है, आप जैसे जैसे हेल्प करेंगे वैसे वैसे आएंगे। आपकी टीम में ये आएंगे, आप मास्क लेके आइएगा, पॉकेट वाला जो मास्क
या हैंकी है,
आप डिफिब्रिलेटर लेते आइएगा,
रुमाल
है ना। वो मास्क कहाँ गया? पॉकेट मास्क दे दीजिए ना इनको। अरे रख क्यों रहे हैं सर जी? वो एनडीआरएफ की टीम, ठीक है। एनीवे, तो आप जो है आपने देखा कि आपके मित्र गिर गए हैं, आप ये मास्क लेके आइएगा जब तक ये आएंगे। और सुनिए ना सर जी, वो डिफिब्रिलेटर दे दीजिए इनके हाथ में। अभिराज आप ले लीजिए। जब आप हेल्प के लिए कॉल करेंगे तो ये लोग आएंगे आपके पास। और आप बाहर थे, कैसे करेंगे सीपीआर? प्लीज डू इट। सब कुछ आपको स्टेप जैसे मैंने किया है, सारे स्टेप्स दिख रहे हैं। एक आपके
सर
पूछेंगे कि मतलब आप करते जाइए, आप करते जाइए, कोई नहीं है आपके आसपास। हाँ नहीं है। आर यू ओके? नॉट रेस्पॉन्डिंग, कोई रेस्पॉन्स नहीं है।
पल्स चेक करेंगे,
एब्सेंट नहीं है। अच्छा पहले करने देते हैं सर, पहले करने देते हैं।
या ऐसे सर?
लेट हिम,
हाँ।
लेट हिम डू। हाँ करिए, करिए ना, पहले करिए, ठीक। अब क्या करेंगे? आप करिए ना, प्लीज करिए, हम लोग सब देख रहे हैं।
आप
पहले तो आप सही से बताएं, लाउडली लाउडली बोलिए।
हॉल बी में एक आदमी गिर गए हुए हैं, उनको कोई ये लगता है शायद कार्डियक अरेस्ट है। जो भी अवेलेबल है जल्दी से यहाँ पे आ जाएं प्लीज। हॉल बी में, हॉल बी में। यस यस यस।
आप सर थोड़ा सटिए इसको। हाँ हाँ हाँ। हेलो 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 हेलो।
आगे झुकिए, करते जाइए, बोलते जाना है, बोलते जाना है।
1 2 3
बोलते जाना।
और फास्ट, पुश हार्ड, पुश फास्ट, पुश हार्ड, पुश फास्ट, पुश हार्ड, पुश हार्ड, फास्ट, push hard, push fast, push hard, push fast. Successful CPR depend upon push hard, push fast, minimum interruption,
हड्डी टूटे तो
chest
डरे
recoil,
नहीं,
है ना?
ठीक है, हड्डी टूट सकता है, रिब टूट सकती है, लेकिन डरना नहीं है। रिब टूटेगा परंतु व्यक्ति बचेगा। और हल्का करेंगे, आप ऊपर ऊपर दबाएंगे तो फायदा नहीं है, कुछ नहीं होने वाला। क्यों सर?
ये फर्स्ट माने मैं पहली बात कहता हूँ कि सीपीआर में सबसे इम्पोर्टेंट है जब डिटेक्ट करें, और उसके पास आपके पास सबसे इम्पोर्टेंट चीज़ है टाइम। यदि आप 10 मिनट में बोले सर कि हमारे शरीर में एक बार में 1 मिनट में 200 सीसी ऑक्सीजन की आवश्यकता होती है, और आपके टोटल शरीर में 10 मिनट के लिए ऑक्सीजन करीब करीब 1 लीटर होता है। यदि इस 1 लीटर के समय के कंजम्पशन के बाद भी आप सीपीआर नहीं करते हैं तो
चेंज करिए, रोल चेंज करिए, है ना? मशीन है, मशीन अटैच करिए।
देखिए डायग्राम बना, वैसे नहीं हगड़ाना नहीं, खड़ा बना। डायग्राम देखिए।
समय सबसे इम्पोर्टेंट है सीपीआर के किसी भी प्रोसेस को अप्लाई करने में।
क्या लगाया आपने? इसको ठीक करिए, ये सही है। हाँ देखिए बना हुआ है, कॉलर बोन है ना, कॉलर बोन।
और चेस्ट से अवे 10 सेकंड से ज्यादा नहीं रहना है। चेस्ट कंप्रेशन किसी भी सूरत में 10 सेकंड से ज्यादा नहीं रुकना चाहिए। यदि कोई भी डिस्टरबेंस हो जाए, घर में या कहीं आसपास कार्डियक अरेस्ट हो रहा हो, तो छाती के ऊपर का जो दबाव है, जो चेस्ट कंप्रेशन है, वो 10 सेकंड से ज्यादा नहीं रुके। जैसे ये सारे प्रोसेस में वो रुके नहीं, और एक आदमी थक जाएगा, आपस में उसको रिप्लेस करें। इज इंपॉर्टेंट फॉर एवरीवन। जैसे ही कोई एक थक रहा हो दूसरा करे, लेकिन छाती का कंप्रेशन करते रहे। सांस नहीं भी दे पाए लेकिन छाती का कंप्रेशन करते रहेंगे, अस्पताल सक्सेसफुल जाएगा। और इस वीक में इस वीक में सर आईसीयू में एडमिटेड है एक लड़का, और वो वीडियो देख रखा था, उसने अपनी फादर को सीपीआर करते हुए लाया है और आज कल उसको डिस्चार्ज किए हैं। ये दिस वीक स्टोरी है, मेरे मतलब है ही वाज उस लड़के ने कहीं वीडियो देख रखा था, उसके फादर को कार्डियक अरेस्ट हुआ, वो लेके आया और आज मुझे डिस्चार्ज कर रहे हैं। मैं तो सोचा था उसका वीडियो मैं रिकॉर्ड करके दिखलाऊं, लेकिन बहुत बार वीडियो पे भी लोगों को ट्रस्ट नहीं होता है, कि लगता है वीडियो भी बहुत फेक है। सो जो कह रहे हैं उसको भरोसा करें, जिंदगी आप जरूर बचाएंगे।
Just we have a living example. One of our surgeon colleague, we had a cardiac meeting here.
शेयर करेंगी।
She is my wife, sir.
जी सर, प्लीज शेयर करिए।
हम लोग सारे लोग गए हुए थे मॉर्निंग वॉक में, मॉर्निंग मैराथन में
और
गए
आगे
हुए थे।
ये तलहट भी आगो।
दिल वहाँ घंटाघर चौक के पास हम सारे लोग वहीं थे। उसके बाद उनको थोड़ा सा मनी जी ने
ये क्यों नहीं है ना, इसको फॉल्ट नहीं होना।
CPR was given, he was in cardiac arrest, he is totally fit and fine now. He is a living legend over Bhagalpur.
और छोड़ना भी है। 1 2 3 4 5 6 7 8 much better. Yes, sure, please come. Please, most welcome. Excellent.
You have to repeat it up to 30 cycles, then 2 cycles of respiration is to be given to the patient, to the victim.
Please come. अब उनको दे दीजिए करने।
चलो
चलिए प्रैक्टिस करिए। नहीं ऐसे नहीं, पहले तो आप इसके ऊपर बिल्कुल
आपके वजह से बहुत बल मिला ना।
नहीं सर, हमको 11 बजे फोन
ये कभी फॉल्ट नहीं होना चाहिए। क्या होनी सीपीआर देने में पूरा
और बोलना भी है, 1 2 3 4 बोलना भी है।
2-3 इधर ले आइए भाई।
2-3 ले आइए ना, बाकी लोग देखिए मैडम, इधर इधर आप देखते हुए करिए, है ना, जस्ट लाइक कॉफी मी, है ना, यहाँ पे ऐसे रखा, है ना, 1 2 3 4 5 6 7 8 9 10, बाकी ले आइए ना मैनिक्योर, प्लीज डू इट। हाँ, बेटर, मच बेटर। कोई भी जिधर भी आपको मिले, टाइम बर्बाद नहीं करना है बस।
ये बोलना जरूर है, जब आप CPR कर रहे हैं 1 2 3 4 बोलना जरूर है, इससे ज्यादा आपका नंबर नहीं होगा। दूसरा, जब भी वेंटिलेट करना है तो ओवर डिस्टेंट लंग को नहीं करना है।
बहुत इंपॉर्टेंट बात बोले, ये नहीं कि जोश में आके पूरा फूंक दिए, हल्का सा फूंकना है, जैसा कि किशोर ने बताया। थैंक यू, थैंक्स ऑल, बहुत बढ़िया।
एक दूसरे को ट्रेन करें, इससे अच्छी बात और कुछ नहीं हो सकती है, है ना। देखिए
वही चीज हुआ,
इसका लोअर पार्ट
बिल्कुल। जरा भी उसमें हेजिटेट नहीं करना है। यू कैन कॉल वन फीमेल टू बी देयर। जैसे हम लोग एग्जामिन करते हैं तो फीमेल को रखते हैं, बट हेजिटेट नहीं करना है।
अब बढ़िया इतना जल्दी नहीं भागना, नहीं स्थिर रखिए हाथ को।
देखिए दोनों हाथ को लॉक कर दिया आपने। गड्ढे पे रख लिया बीच में, करते गए करते गए करते गए, सिंपल है। और किसी को आप लोगों को करना है, आइए आइए, आप लोगों को करना है। somebody wants to do it.
सारे लोग आइए, हम
हाँ हाँ,
ऐसे टेढ़ा नहीं बाबू, आप बिल्कुल ऐसे आइए, इसके ऊपर आइए, हाथ को पीछे लेके जाइए, हाँ, इसको सीधा रखिए, अब लगा कर। यस, स्पीड का ध्यान रखना, 200 भी नहीं कर देना है ना, टाइम देना है हार्ट में वापस ब्लड आने का। 1 2 3 4 5 6 7 8 9 10 11 12।
आफ्टर 32 ब्रेथ्स।
और जिसको करना है प्रैक्टिस,
चलिए आइए करिए, बिल्कुल करना
बहुत
है,
बढ़िया, एक्सीलेंट।
करिए।
और आप सब लोग जाएंगे, आप अपने सारे कलीग को ट्रेनिंग देंगे।
और मैं इतना तेजी से ज्यादा क्या देना रिक्वायर होने का भी है ना।
कितने सर्टिफिकेट हैं यहाँ पर? कितने सर्टिफिकेट हैं यहाँ पर?
काफ़ी
है
अभी
सबको नहीं
देखे। हाँ
उसको दे दें। हाँ ठीक है, यू आर सेटिस्फाइड? थैंक यू सो मच।
1 2 3 छोड़ना ही है 4 5
इन लोगों को खाना खिला दीजिएगा, जब ईट खाना खा के ही जाएगा, कोई कूपन ऊपर नहीं। मैं हूँ ना, चिंता क्या करना है। इन लोगों को खाना खिला के आप लोग खा नहीं
सर
सुनिए, आप हमारे गेस्ट हैं।
नहीं गेस्ट क्यों सर, हम
अरे
वेदांता के साथ।
प्रिकॉशन भी देखना है,
एकदम इसके ऊपर ऐसे अब सही
जैसे कि देने में देखना है हर चीज़। अगर
छोड़ना भी है ना।
हेलो, क्या नाम
1 2 3 4 5 6 7 8 9 10 11 12